Good evening, and welcome to the 5th Annual OREF Resident Research Symposium. I'm Dr. Joshua Jacobs, President of the OREF, and on behalf of the OREF Board of Trustees, I'm honored to be here tonight to welcome you to this exciting event. I'd like to extend a special welcome to everyone joining us this evening via the live stream. Next slide, please. Between May and October, OREF held 5 regional symposia with our co-hosts at the University of Miami Miller School of Medicine, the University of Pittsburgh, the University of Chicago, next slide, the University of California at San Francisco, and the Hospital for Special Surgery. This evening, the top finishers from those 5 symposia will compete for the title of OREF National Resident Research Symposium Grand Champion. Next slide. I want to recognize and thank you to our keynote speaker, Dr. Feeley, who I'll introduce later in the program. Next slide. And also thank our judges for this evening, who I'll introduce a little bit later, Andy Pollack, Matt Silva, and Brian Schneider. Now I'd like to turn the podium over to OREF's CEO, Lee Grossman, who will tell you more about the program. Lee?
Thank you, Josh. And it's a pleasure being here. Providing this incredible resident research experience requires resources. And I want to offer our sincerest thanks to our 2025 sponsors for their support of this program. Thank yous go out to Smith & Nephew, Johnson & Johnson MedTech, and Zimmer Biotech. I'd also like to recognize some very special individuals who provided generous financial support for the 2025 symposium. Those included the Hart family, who's been very generous to OREF over the last few years, and their support of our symposia this year has been fantastic, and we are very, very grateful to them. I'd like to give you a brief overview of OREF and our mission impacts and what it does for clinical practice and patient care. OREF is an established leader in the MSK community. We're committed to funding research and ensuring our specialty continues to innovate and grow. And we do that by nurturing new investigators with seed funding and education opportunities. OREF is 100% donor funded, which allows us to be independent and fund what is most important at any particular time. We see ourselves as a unifying force in orthopedics. The chart that you see here represents the past 5 years, and the percentage of funding for a given subspecialty or topic will change as the time period changes. As you can see from this chart, OREF funds all aspects of MSK and MSK research. The grants here are categorized based on the primary category selected by the investigators when applying for the grant. In the middle, you'll see the amount of money that we have designated for resident education programs. And as I said, OREF is very collaborative. We collaborate with over 60 other MSK organizations. And over the last 5 years, we provided over $4 million to support their research activities as well. Our total mission support has been almost $20 million over the last 5 years. We enjoy broad support from institutions that are training tomorrow's surgeons and surgeon scientists, as well as practicing surgeons. As you can see from this chart, these are the institutions last year, hospitals and physician groups that have supported OREF's mission, and we're, again, extremely grateful to them. We also want to talk about our impact and how successful we've been over our 70-year history. As you can see from this, this was a study that was conducted by Dr. Nick Bernthal at UCLA, and it showed that OREF grant recipients continue to secure more federal funding at a higher rate than other applicants. OREF grant recipients leveraged $34 million in OREF funding into more than $200 million in federal funding. The federal return on investment across all grant programs averaged approximately 503%. And these outcomes highlight OREF's effectiveness in selecting and supporting promising surgeons. here's another study that talks about our impact and the way that we support resident grants and their recipients. And it shows that of those that have received, the residents that have received grants from us, about 64% of them have selected an academic career. And there was a study published this past year in JOR that found that 42% of our regional symposium winners pursued academic careers. So that's very relevant to the people that are presenting this evening. Again, talking about our impact over the years, there was a study conducted by Dr. Tom Skokol, Dr. Jim Heckman, Dr. Seth Greenwald, and supported by OREF Vice President of Research and Grants, Dr. Deborah Cummins, who looked at our 4,900 grants that we have funded over 70 years and shows the approximate 250 grants that went on to change significantly clinical practice. And what you see on this slide is a very, very small sampling of some of those more significant grants that we have funded over the years. We wouldn't be able to go through this presentation without talking about the burden of musculoskeletal disease and its impact on and the disparities that exist between that burden and the research to MSK projects. MSK issues dominate healthcare. It's approximately $1 trillion a year. It's about 5% of GDP. It's that enormous. It dominates healthcare in terms of costs as well as procedures. But yet, even with that great burden of disease, MSK funding is among the lowest of any disease conditions. As you can see from this grant, it's very, very low in comparison to other disease conditions funded through NIH. And it's something that we have to address. And as a community, OREF is trying to unite the community to address this growing issue. It's been worsened with the funding cuts through the federal government this year. And this is a time for the community to come together to support more research funding in MSK. One of the ways that we're addressing this is that we've developed a paradigm to organize research in MSK into 3 categories of pain, emerging technologies, and biologics. And we do this through all of the projects and the way that we address the field of orthopedics. We do this through addressing the burden of disease, for being assertive advocates in federal funding, to support emerging technologies through big data and AI, and to support early career scientists throughout their careers. One of the ways that we have had in doing this is to support residents in giving to OREF with the understanding that OREF residents that give early in their careers will maintain a relationship with OREF over the years in giving to us and supporting our mission as it goes forward. We've been supported over the years by McDACTA, who has matched the dollar for dollar that residents have provided to OREF. With that, I want to say thank you to everybody listening. Thank you for the residents that are participating tonight for supporting OREF. We're the only orthopedic organization committed solely to funding research in all subspecialties that improve clinical practice and patient outcomes. So tonight, we're here to welcome the winners of the regional symposia. As you can see here, these are the last 4 national champions that we have that were selected. The winner of tonight's symposia wins an all-expense paid trip to New Orleans, the American Academy of Orthopedic Surgeons conference next March, as I said, in New Orleans. So with that, good luck to all the presenters tonight. Thank you to everybody listening, and please support the mission of OREF. With that, I'm going to turn this back over to Dr. Jacobs, who will provide some of the other information in terms of the process for this tonight's activities. Thank you all.
Thank you, Lee. I'm very happy to be serving as a moderator for this incredible program. Tonight's presentations have been divided into 3 sessions, and each will be scored on 8 criteria, including whether the data presented advanced our understanding of the topic. Our judges this evening include Dr. Andrew Pollack, who is the Executive Vice President at the University of Maryland Medical System, former chair of the Department of Orthopedic Surgery, University of Maryland, and currently the president-elect of OREF. Also joined as a judge is Dr. Brian Snyder, a clinician scientist at Children's Hospital in Boston, and Dr. Matt Silva, a bioengineering researcher at Washington University in St. Louis. All of our judges this evening are members of the OREF Research Grants Committee, which works tirelessly to identify the most promising applications for funding that will push forward the research agenda and clinical care in our profession. I want to remind our judges and presenters to open the scoring survey links that you were sent by our grants team and ensure you're able to access the sheet. If you have any problems with your sheet, please contact Carmen Montoya at the number she provided in her email to you. Please score each presenter as the program proceeds. Also, during the Q&A following each session, judges and presenters may unmute to ask questions. Those watching the live stream may submit questions by sending an email to grants@oref.org. And now, without further ado, let's start the presentations. And our first presentation will be given by Joseph Geller from Jackson Memorial Hospital, the University of Miami. His research presentation is entitled Tracking Wearable Device Compliance in Total Knee Arthroplasty Recovery. Dr. Geller, congratulations, and looking forward to your presentation.
Thank you, Dr. Jacobs. Can you see my screen?
Yes.
Okay, so my name is Joseph Geller. I'm a PGY5 at the University of Miami, and tonight I'll be presenting on wearable device compliance after total knee arthroplasty. I have no disclosures. So wearable technology is something that can provide both surgeons and patients a significant amount of data detailing patient recovery. I think it's especially pertinent after total knee replacement, which is one of the most commonly performed surgeries in the United States. Previous studies have shown us that social determinants of health can significantly impact patients' abilities to interact with wearable technology. And so the goal of our study was to evaluate the impact of demographic variables involving social determinants of health on specifically the track patch wearable device technology compliance rates after total knee replacement. So what is the track patch? The track patch is a device, and you can see here on the left-hand side of my screen, it has 2 components which are attached to the lateral side of the leg via an adhesive. And the track patch device allows us to capture significant information about patients postoperatively after knee replacement, including body movements, knee flexion, step counts, local temperature. And this information is then sent to an application that can be accessed by the patient on their smartphone, and they can actually actively interact with this application. They can choose to do certain exercises. They can submit wound photos. They can look and see their recovery and compare it to other patients' benchmark recovery as well. And then this information is also sent to providers and to physicians. And so we are able to evaluate objective data about how patients are doing without actively having to see them in the office. And so, like I said, the track patch provides us with continuous objective data. And what it really does is when we collect the data for enough patients, it allows us to establish recovery benchmarks. And then we can identify divergent cases in patients who are potentially at risk of having a complication when they're not reaching those benchmarks in their recovery. So we collected multiple demographic variables that have been known social determinants of health, including primary language, ethnicity, sex, BMI, age, and insurance type. And then we use these variables to evaluate how patients were complying with their wearable technology after their knee replacement. There were 2 types of compliance that we defined in this study. The first one is passive compliance, and that simply means, is the patient wearing the device? Do they wake up in the morning, take the device off the charger, and do they attach it to the adhesive on the side of their leg? And then on top of that, there's active compliance, which is the patient actively interacting with the application? Are they submitting progress tests, conducting exercises, submitting photos of their wound? Are they actively complying with the device and really taking control of their recovery? We prospectively enrolled 188 patients in the study. The majority of our patients were female, as you can see here on the left-hand side. Average patient age was between 60 and 80, and most of our patients were very overweight or overweight. Given that this took place in Miami, the majority of patients were Hispanic or Latino, and English was the most common primary language that was spoken. And these are our results in a snapshot. And so I'll explain it by each column. On the left-hand side, you have the different demographic variables. So here you can see insurance status, ethnicity, language, and sex. And then in the middle column, we have passive compliance, the average number of days that the patients passively wore the device after surgery. And then on the right-hand side, it was active compliance. So the number of days that patients are actively interacting with their application and their recovery. And essentially what we found was that there were no significant differences in patient active or passive compliance rates for any of these demographic variables. So whether they had Medicare insurance or a different insurance, whether they were Hispanic or non-Hispanic, whether English or Spanish was their primary language, we found that with all of the demographic variables that we evaluated, that patients were similarly utilizing the wearable technology after their knee replacements. And so I just want to show you some graphs of the information that's provided with this wearable technology. So on the top graph, this is passive compliance rates, and we can see that patients are passively wearing their wearable technology device well into the second month postoperatively, whereas in the bottom graph, that's active compliance, and you can see that there's more active compliance in the first month, and that tends to slow down as patients progress. We can also get valuable information such as knee flexion. So we have maximum degrees of knee flexion on the left side, and then we're looking at days post-operatively. And you can see here that patients' knee flexion continues to increase over their first 2 months post-operatively, and it really gives us a benchmark of where most of our patients are. And this is what allows us to look at a graph like this and say, oh, this patient is far below the average knee flexion for this time period post-operatively. Perhaps we should contact them and bring them into the clinic. The same is true of step count and even patient temperatures, which we can obtain with this device as well. And then it also tells us how often is the patient moving on postoperative day 0 versus postoperative day 30. The patient spends a significantly more amount of time moving the knee, more time with the knee bent, and less time with the knee straight as time goes on. So when patients aren't meeting these normal values, these are patients that are potentially at risk and ones that it's helpful for us to identify early on. So in conclusion, wearable devices such as TrackPatch allow both patients and physicians to effectively monitor patient recovery with objective data and quickly identify patients who are at risk for outcomes like stiffness, blood clots, and even infection. In our study, on average, patients demonstrated higher active compliance in the early postoperative period, but they continued to passively wear the device well into their second month postoperatively. And then finally, our primary outcome, social determinants of health, we found no significant differences between any of the demographic variables that we evaluated and patient utilization of wearable technology after knee replacement. And so we concluded that social determinants of health do not appear to affect patient compliance or utilization of the wearable technology. I just want to say thank you to the OREF for having me, as well as to my mentors at the University of Miami. Thank you.
Thank you very much, Dr. Geller. Excellent presentation. We now turn to Dr. Julia Retzky from the Hospital for Special Surgery, New York City, who's going to discuss early ACL reconstruction, mitigates in a post-traumatic OA, marine ACL rupture. Dr. Retzky.
Perfect. Thank you, Dr. Jacobs. My name is Julia Retzky. I'm coming from Hospital for Special Surgery, and I'll be presenting our project looking at the impact of the timing of surgery on the development of post-traumatic osteoarthritis using our mouse ACL rupture model. So it's well known that up to 60% of patients will develop post-traumatic osteoarthritis, or PTOA, at an average of 10 to 25 years following ACL reconstruction. And while some studies suggest that early reconstruction may mitigate PTOA, others have found no difference in the timing of surgery on the development of arthritis. So the optimal timing of ACL reconstruction in order to mitigate PTOA has not yet been fully elucidated. And the impact of both the local and systemic immune cells on the development of PTOA has not been determined. Our primary aim was to evaluate the impact of the timing of ACL reconstruction on the development of PTOA using our murine, non-invasive, or closed ACL rupture model. Our secondary aim was to evaluate the impact of the timing of surgery on pain-related gait behaviors, both the peripheral and central immune and inflammatory response, knee range of motion, and proximal tibial epiphyseal and distal femoral epiphyseal bone volume. For this project, 55 11 to 12-week-old male black 6 mice were randomized to one of 3 conditions: either an ACL rupture only, ACL rupture followed by immediate reconstruction, or ACL rupture followed by delayed reconstruction at 7 days post-injury. We also had an uninjured control group included in our analysis. Mice in both the immediate and the delayed groups were sacrificed at 28 days post-surgery, whereas mice in the ACL rupture only group were sacrificed at 28 days post-injury. Our primary outcome measure was a histologic evaluation of osteoarthritis using the OREF scoring system. Our secondary outcome measures included knee range of motion, analysis of local and systemic immune cells using flow cytometry, gait analysis, and quantification of distal femoral epiphyseal and proximal tibial epiphyseal bone volume using micro-CT. In order to rupture the ACL, the mice are anesthetized and they're placed prone. An axial load between 5 and 20 newtons is applied to the distal tibia at a speed of 1 millimeter per second in order to rupture the ACL. An ACL rupture is confirmed by a positive Lachman test. In terms of our results, we found worse PTOA at 28 days postoperative in the delayed reconstruction group compared to the immediate reconstruction group. Specifically, we found higher femoral and tibial OREF scores in both the delayed reconstruction and the ACL rupture only groups compared to the immediate reconstruction and control groups. By contrast, we found similar femoral and tibial OREF scores in the immediate reconstruction group compared to the uninjured controls. And these are a couple representative histologic images, again demonstrating worse post-traumatic OA in both the delayed reconstruction and the ACL rupture only group compared to the immediate reconstruction group, which shows preserved cartilage. In terms of range of motion, we found that the delayed reconstruction group experienced persistent stiffness at both 14 and 28 days postoperative, while the immediate reconstruction group initially experienced stiffness. By 28 days, they had regained their motion similar to that of the uninjured controls. We found no difference in pain-related gait behaviors between groups at any time point. Specifically, there were no difference in time in swing phase, time in stance phase, stride frequency, gait symmetry, or paw area at peak stance between groups. To identify the lymph node that drains the knee joint, a separate cohort of mice underwent intra-articular Evans blue dye injection. We found that the ipsilateral iliac lymph node and its associated afferent and efferent vessels retained Evans blue dye following the intra-articular injection. So therefore, we use the ipsilateral iliac lymph node as a readout of the local immune response and the spleen as a readout of the systemic immune response. We found an increase in total iliac lymph node cellularity, but not spleen cellularity in both surgical cohorts compared to the ACL rupture and control group. And finally, we found greater bone volume in both the proximal tibial and distal femoral epiphyses in the immediate group compared to the delayed reconstruction group. So in conclusion, we found that immediate ACL reconstruction mitigates the development of PTOA in our murine ACL rupture model. The ipsilateral iliac lymph node reflects the local inflammatory environment, and chronic unresolved inflammation may lead to progressive PTOA. Although future studies aimed at elucidating the role of reconstruction timing and inflammation on the development of PTOA will allow us to better address this very common yet detrimental sequelae of ACL injuries. In terms of limitations, we use male mice only, and all of our surgeries were done open as arthroscopic surgery isn't possible in the mice. I'd like to thank Dr. Rodeo, Dr. Eliasberg, Dr. Carballo, and the entire Rodeo and Eliasberg labs for all their support throughout this project. And thanks for the OREF for the opportunity to present tonight.
Thank you very much, Dr. Retzky, for presenting that elegant study. We'll next turn to Dr. Katherine Montoya from the University of Arkansas for Medical Sciences, who's going to present 10 years of a novel telemedicine system for management of statewide hand trauma in Arkansas, a decade in review. Dr. Montoya.
Thank you so much. Let me see if I can get this.
Need to swap screens.
You can see that.
Perfect.
Perfect. Okay. Good evening, everyone, and thank you for being here virtually. My name is Katherine Montoya, and I'm a PGY for orthopedic surgery resident at the University of Arkansas. And today we're going to review key findings of a database analysis of encounters collected through the Arkansas Hand Trauma Telemedicine Program, or the AHTTP. I have no disclosures, and this research was not directly funded. Managing hand trauma in any state, but especially in rural states, is difficult due to a myriad of logistical complexities, including but not limited to triage, treatment, interfacility communication, and insurance considerations, just to name a few. In Arkansas, as in many states, there are a paucity of fellowship-trained hand surgeons and few centers equipped to deal with complex trauma. Thus, a geographic mismatch exists between patient need and treatment capacity. In the year 2013, 72.6, or nearly 3/4 of hand traumas processed through Arkansas's trauma system were transferred via EMS to a higher level of care. In 2014, the HTTP was established by a group of 7 fellowship-trained hand surgeons in partnership with the Department of Health's centralized trauma management system. The goal was to improve access to hand trauma care and decrease unnecessary utilization of EMS resources statewide. The Broadband Technology Opportunities Program grant was used to provide every ED in the state with audiovisual technology to securely facilitate telehealth encounters. Funds from the state's tobacco excise tax are used to provide call pay and maintain the program. This is how it works. A hand trauma presents to a local emergency department. They contact a centralized triage entity called the Arkansas Trauma Communication Center, who can connect them with an on-call hand surgeon remotely 24/7, 365. The consulting surgeon will remotely evaluate the patient clinically together with the relevant imaging, and then either recommend temporization with associated follow-up plan or transfer to the hand surgeon on call at their hospital. The objective then of our study was to analyze the database of encounters processed through this system to evaluate its effectiveness as described by interfacility transfer rate, and thus EMS utilization, cost savings, and overall access to expert care for hand trauma. We directly queried the database collected from all encounters from 2015 onward, and the data from the 2 preceding years was obtained from prior publications. This graph details the total number of consults for hand trauma processed through the AHTTP. The blue dot represents the year prior to the program's inception. You can see how tremendously system utilization has grown since its establishment, with almost 1,000 consults in 2023 alone. A grand total of 7,260 consults were fielded in the first decade of this program. Here we have a map which depicts the geographic origin of HTTP consults analyzed in this data set. They originate from nearly every county in our state. Here's the map you just saw, juxtaposed with a map where each star represents one board-certified hand surgeon in Arkansas. The geographic disparity is glaring. This figure depicts hand trauma transfer rate via ground EMS. You can see the marked before and after improvement associated with the establishment of the HTTP. Thereafter, still statistically significant improvements in ground EMS transfer rate have been observed. Here you see a statistically significant downward trend in hand trauma transfers made via air ambulance in Arkansas since the establishment of the telemedicine program. So what's the bottom line? Assuming an otherwise unchanged rate of transfer in the absence of the hand telemedicine program, we estimate that 2,519 ground transfers for hand trauma have been prevented. Using the same assumptions, we estimate that 156 air ambulance transfers have been prevented by the telemedicine program. Importantly, this translates to an estimated cost savings of $12.2 million. This was calculated using the CMS fee schedule for Arkansas with adjustment for Medicare underpayment at 40 cents on the dollar. In conclusion, the HTTP has successfully improved access to expert care for hand trauma across the state of Arkansas. It has facilitated significant decrease in EMS transfer rate, which correlates to an estimated cost savings of $12.2 million. While of course we are excited about those deliverables, we're also proud that observed improvements herein represent an increased availability of EMS services for other patients in need. As we look to the future, we'll be implementing the ASSH's recently published guidelines for hand surgery consultation and transfer to empower local EDs to help ease the burden of the growing number of consults. We anticipate that this addresses what we have noted anecdotally to be an increasingly indiscriminate use of the system. In all, the HTTP has proven an elegant solution to a complex problem. We hope to take what we've learned in our first decade with this program to continue to streamline management of trauma across our state and perhaps serve as a model, especially for rural states, to tackle this difficult demand in emergency surgical care. I just want to thank our research team and the OREF for the opportunity to present tonight.
Thanks, Dr. Montoya, for that very timely and fascinating presentation. The final presentation in this session will be by Dr. Kyla Petrie from the University of California, San Francisco. Dr. Petrie will discuss a comparison of re-tear rates and all-cause reoperation rates in pediatric and adolescent ACL reconstructions using bone patellar tendon and quadriceps tendon grafts. Dr. Petrie.
All right. Can you guys see that okay?
You need to go to the show.
Should be in presenter mode. Otherwise, it looks good.
All right.
There you go.
All right. Thank you all. My name is Kyla Petrie. I'm a fourth-year resident at UCSF. I'm going to talk briefly today about ACL tears and reconstructions using BTB tendon and the quad tendon autografts in the pediatric and adolescent ACL tear population. All right, and so no relevant disclosures today. And for a background, and so for pediatric and adolescent patients, their rate of ACL tears has continued to rise, and this is at a rate higher than adult tears, especially as more and more of these patients are continuing to single sport specialize and things like that. But unlike the adult population, these young patients have a bit of a higher risk when they undergo reconstruction of the ACL. Both for re-tear, they have a higher rate of re-tear down the line, and then also concerns around growth disturbance in the physis. And, you know, the big question with ACL surgery is always graft choice and what graft should be used. And for this pediatric and adolescent ACL tear population, hamstring graft has shown a higher failure rate when compared with BTB. But this BTB graft
Why don't you start? Let's see here. Yeah, why don't we start there?
Okay. Sorry, I will be quick about this, but essentially we are trying to figure out if there are any differences in re-tear rates or reoperation rates between BTB and quad tendon autografts in pediatric and adolescent patient populations. So this was a retrospective study. We looked at all ACL reconstructions with either BTB or quad tendon autografts between 2013 and 2023 for the senior author. So we collected a number of demographic variables, including age, gender, graft type, whether or not they played a high-risk sport, if they were compliant with the postoperative protocol, and then whether they had a repeat surgery or their graft tore. So our outcome measures were whether or not the graft tore and whether or not they had the repeat surgery. And then we also tried to collect more long-term data since some of these patients had their ACL reconstruction several years ago, where we looked at if they had any graft re-tears that were not collected in our chart review, or if they had a repeat surgery, and whether or not they returned to sport and what their IKDC score was. And so results, so basic demographics, our population was about 60% male, about 40% female. The average age was just over 16 years old, and then about 70% had a BTB, where about 30% had a quad tendon. The average graft diameter was about 9 millimeters. And so our main statistically significant finding was that there was a difference in the rate of repeat surgery. So with the BTB graft, it was about 5.6%, and the quad graft was 1.3%. When we look at graft tear, BTB rate was a little bit higher at 3.2%, with the quad tendon being only 0.6%. However, that rate was not statistically significant. And we did find that an average IKDC score was about 86, and about 63% of these patients returned to the same level of sport. And so looking a little bit further at what was associated with re-tear, we found that gender and compliance were both associated. So all of those who retore were male, and then 83% of those patients who retore their graft were not compliant with the postoperative protocol. And then looking kind of further at our more long-term follow-up, it was about 6 years. We found no further reports of re-tear that we didn't already see in our chart review. We did also find that the graft type was not associated with the patient's return to sport. But we did find that their rate of return to sport was associated with higher IKDC scores, and that gender approached significance. So about 70% of the male patients returned to sport versus only 45% of the female. So in conclusion, I think, takeaways from our study was there was a higher rate of repeat surgery with the BTB when compared to the quad autograft. And though the graft tear rate, re-tear rate was higher with BTB, that did not end up being significant. And then gender and postoperative protocol compliance were both associated with graft tear. Limitations-wise, we did have an overall low number of graft tears in this patient population, which may have contributed to our findings of significance. This also was a retrospective study, and then we were only able to get kind of this more long-term follow-up from a quarter of our patients. But I think, the biggest question that we always ask for this research is how might this change practice? I do think this can inform some decisions on graft choice for adolescent and pediatric patient populations who are undergoing ACL reconstruction. Here are the references, and then thank you to my co-authors and study team.
Thank you, Dr. Petrie. Great recovery after a little bit of snafu. So we are a few minutes behind schedule. Nonetheless, I think we can have 5 minutes or so for a Q&A for the 4 presenters in this session. Any of the judges have any questions? Brian, I see you there. And you're on mute if you're trying.
So for Dr. Retzky, so here's a question. So how do you know that the difference had anything to do with the reconstruction as opposed to early washout of the hemarthrosis and neutralization of metalloproteases and IL-6 and interleukin and TNF-alpha? Because one of the standard models, for example, is medial meniscus sort of destabilization to create, but it may be just the early washout neutralization was enough to prevent the OA.
Thank you for your question, Dr. Schneider. We actually have 2 ongoing studies. One is evaluating the effect of immediate hemarthrosis evacuation on the development of P2A. So we had mice where we evacuated the hemarthrosis and ones that we didn't. And we're in the final stages of histology collection right now. So we'll have that data shortly. And to answer your question about the MMPs, we have a separate ongoing study where we're injecting either anakinra, alpha-2 macroglobulin, or corticosteroid into the knee immediately after the ACL injury. And our histology is almost complete for that as well. So it's possible that those are very likely contributing to the development of PTOA, and we'll have those answers shortly. In terms of the menisci, I know DMM models are commonly used to induce OA, and we looked at that. We sacrificed a cohort of mice at 7 days post-injury to look at the status of the meniscus, and they were all intact at that point. So it truly is an isolated ACL rupture. But you raised great points. We're very interested in the role of both the hemarthrosis and inflammation after this injury on the development of arthritis.
Great. Dr. Silva, you had a question.
Yes, I question for Dr. Petrie. So you found a difference, I think, in reoperation rate for higher in the BTB graft versus
Correct.
the quads. Well, how does that compare to what's known in the adult population?
I think from my understanding for the adult population, there is not a difference so far that's really been elucidated. So yeah, I don't know that I have a great sense of why the BTB had a slightly higher reoperation rate at this point. But I think that's you know, a good place for future study and future questions.
Thank you. Dr. Pollack.
Yeah, thank you. For Dr. Montoya, you showed an association between the teleconsult program and the decrease in the transports over time, but did you look at any other transport diagnoses that didn't have associated telehealth consults over that time to be able to ascertain over that time period whether it was actually the telehealth consults or something else that was happening in the system or the overall utilization of transports that drove the number down?
Thank you so much for that question, Dr. Pollack. It would have been nice if we could do that, but at that time when the telehealth program was rolled out, all of the hand trauma that was previously processed through like the generic or like the all-comers trauma system was diverted into the telemedicine system. So there was no control for hand trauma specifically. Like all of it went from one system to the next. But for other injuries, like we did not compare it to like legs or, you know, axial skeleton trauma or anything like that. So it could be useful, but we don't have a control group for hand.
Thank you. I'll ask the final question for Dr. Geller. Fascinating study. I might have missed it. What is the expense of this track patch? Is this feasible for routine use following total knee arthroplasty?
Thank you, Dr. Jacobs. That's a great question. I don't know off the top of my head what the exact cost is of the track patch. I don't know what the cost is to the patient for this study. This was through a grant in which the university paid for these. It was not an expense to the patient. But that's a great question. It certainly is an added expense. And if patients had to foot the bill for the track patch or for any other kind of wearable device, I'm not sure if they would choose to select it or not. That would be a good questionnaire or something to ask patients, and maybe prospectively enroll them based on that.
Well, thanks so much. I want to thank all the session one speakers. Certainly a great geographic distribution from Miami, New York City, Little Rock, and San Francisco. Amazing. I want to remind the judges and presenters to complete the scoring survey for session one presenters in this time. We're going to take a short break in just a moment, but before that, we have a short video we'd like to share, and I'd like to welcome back Lee Grossman to introduce the video.
Thank you, Dr. Jacobs. The video we're about to see features an OREF Sustaining Order of Merit donor, Dr. Leslie Dean. And in this video, she's explaining why supporting research through OREF is so important to her. I'd like to thank Dr. Dean for her support and the important reminder about the value of research to clinical practice. Also, this is a very important time of year to support OREF's annual fund. So I encourage all of you to go to OREF's website during the break and give generously so we can continue to improve patient outcomes, grow the pipeline of clinical researchers, and bring innovation and advancements to clinical practice. Now, here's Dr. Dean.
Hello, my name is Leslie Dean, and I'm in Anchorage, Alaska. I'm a retired hand surgeon. I've been contributing to OREF quite some time. I had not been keeping track of the OREF. I've been contributing at the Sustaining Order of Merit for over 25 years, just giving $1,000 a year. I do that because early on in my career, I knew that I had absolutely no interest in research, but I think that research is vitally important to our profession. Profession is fantastic, and we truly build on where when we practice, we're on the shoulders of the giants who went before us. I know that continuing education is critically important, but also research And I felt that the best way for me to contribute, to continue the advancements in our profession, is to contribute to OREF. I have no knowledge, aptitude to determine what research is appropriate. But OREF, they're the experts. They're able to evaluate and vet programs. So again, I think that's the best way for me to contribute. I get the best bang for the.
Thank you for that important message from Dr. Dean. We will now take a 5-minute break. Again, judges, please enter your scores, and as well as the other presenters. And we will return at 6:28 Central Time. Thank you. It is now 6:28, so why don't we go right into session 2. Welcome back. The first of 5 presentations in this session will be given by Dr. Olivia Araujo from Jackson Memorial Hospital, University of Miami. Her topic is entitled Consideration of Updated Breast Cancer Screening in Female Orthopedic Surgeons, a Comprehensive Review. Dr. Araujo.
Thank you so much. My name is Olivia Araujo. I'm a PGY2 in Miami, and I'm very honored to present to you today our project, Consideration of Updated Breast Cancer Screening Guidelines in Female Orthopedic Surgeons, a Comprehensive Review. We have no disclosures. So as we all know, fluoroscopy is a fundamental part of orthopedics, and it correlates that increased occupational radiation will place female orthopedic surgeons at an increased risk of breast cancer. Previous studies have noted a higher prevalence of breast cancer among female orthopedic surgeons compared with US matched women. And current breast cancer screening guidelines recommend yearly mammography beginning at age 40, leading to a mean lifetime glandular dose of about 0.25 to 0.3 rem, in addition to the occupational exposure sustained by some women. So the purpose of our study was to consider if breast cancer screening should be modified for female orthopedic surgeons from mammography to a non-radiating form of screening exam, such as ultrasound or MRI, due to the occupational radiation exposure sustained by these physicians. So to do this, we performed a comprehensive literature review with the following parameters listed on this slide. And of 165 total studies, the ones were screened for relevance and reviewed for inclusion in our literature review. We found after doing this that compared to the general US female population, there's approximately a 4 times greater prevalence of breast cancer among female orthopedic surgeons, and among orthopedic, plastics, and urologic surgeons, female orthopedic surgeons reported the greatest use of fluoroscopy, had a higher odds of breast cancer, and a standardized prevalence ratio up to 2.9 in one study. The mean radiation dose at eye level per orthopedic procedure did vary from about 0.002 rem with femoral nails and pelvic fixation, reaching up to 0.031 rem per single procedure. But the question still remained, should we consider modified radiation-free screening? So in one study, the mean annual occupational exposure for a resident in a Canadian orthopedic surgery program was 0.33 rem, leading to an exposure of about 10 rem over a 30-year career. OSHA guidelines currently recommend a prospective annual limit of 5 rems a year. So if we took this together, at about 15 years, some orthopedic surgeons might be reaching their lifetime recommended limit based on occupational exposure alone, not to regardless of if they're having their mammographies or not. So thinking toward the future, we certainly advocate for mitigating exposure. This can be done through the addition of lead sleeves or axillary supplements, where this particular study found a reduction of about 97 millirems per hour to approximately 1 millim per hour when measuring the mean scatter radiation to the upper outer quadrant of the breast, which we know is the highest risk region for breast cancer development. However, access to these specific styles is not uniform. It can be quite expensive, depending on the companies that your institution has a relationship with and what resident education provides for. However, this image you can see in the bottom here, image E, shows the axillary supplement found to have the greatest reduction in millim per hour exposure to the upper outer quadrant. The same study did note that there is significantly higher radiation exposure with C-arm cross-table lateral shots compared to AP projections. So something else that women should keep in mind in the OR. So additionally, we wanted to know, should we consider a screening ultrasound and a diagnostic MRI for women working in fields with occupational X-ray exposure as opposed to mammography? Based on the 2023 American College of Radiology guidelines, women considered at higher than average risk of breast cancer should undergo a mammogram with supplemental MRI, but they're still undergoing this mammogram. And meanwhile, we know that X-ray radiation has been causally linked to the development of breast cancer, and digital mammography does induce itself a 0.37 rem per breast per exam exposure. This is equivalent to approximately your residency. So when you consider the imaging options, like I mentioned, mammography is the most common screening test, has approximately 70 to 80% sensitivity, but decreased in women with dense breast tissue. And then ultrasound is a little bit more sensitive than a mammogram, but may not be as specific. And then MRI is the high specificity, but very variable specificity, high sensitivity, very variable specificity, so more false positives. So there's no perfect test. However, at the conclusion of our study, we still don't have real clarity for women working in fields with occupational exposure to radiation. Would they benefit from ultrasound and MRI alone rather than supplemental studies in addition? So from our review, guidelines have yet to be changed for female surgeons, as well as those who are working in fields with radiation exposure. But we advocate for future collaboration with the American College of Radiology for updated screening guidelines, and then providing well-fitted lead for all providers, including residents, particularly as residents are working in additional surgical centers, covering more hospitals. It's very important to consider this when providing for the education funds. Thank you very much.
Thank you for presenting the result. A very important topic. We'll move to our next presentation from Dr. Zachary Herman from the University of Pittsburgh Medical Center, who's going to discuss overhead athletes have comparable intraoperative injury patterns and clinical outcomes to non-overhead athletes following surgical stabilization for first-time anterior shoulder instability at average 6-year follow-up. Dr. Herman.
Thank you. Sorry for the mouthful on the title. Thanks, everyone. My name is Zach Herman. I'm one of the fifth-year residents from the University of Pittsburgh. Today, I'll be speaking on the clinical outcomes of overhead versus non-overhead athletes following shoulder stabilization surgery. So oftentimes, anterior shoulder instability presents in non-overhead contact athletes after traumatic events in the form of dislocations. But overhead non-contact athletes are more likely to present with subtle instability secondary to repetitive microtrauma in the form of subluxation events. Previous research has shown that overhead athletes and throwers with superior capsular or labral pathology, like slap tears, have decreased return to sport rates and increased complication and revision rates when compared to non-overhead athletes after surgical intervention for this type of pathology. It remains unclear, however, how participation in overhead sports should affect algorithms for the treatment of first-time anterior shoulder instability. As such, the purpose of the study was to evaluate the clinical presentation, outcomes, and recurrence and revision stabilization rates of overhead versus non-overhead athletes following stabilization after first-time instability episodes. And we hypothesized that overhead athletes would have milder clinical presentations, similar surgical characteristics, but diminished postoperative outcomes when compared to non-overhead athletes. So the study was a retrospective review of consecutive patients between 2013 and 2020 at a multi-center regional healthcare system with minimum 2-year follow-up. Inclusion criteria included surgically managed patients following first-time anterior shoulder instability episodes, and exclusion criteria included prior stabilization, revision surgery, and multidirectional or recurrent instability. Dislocation was defined as events requiring manual reduction and confirmed with MRI findings such as anterior labral tearing plus or minus a Hill-Sachs lesion. Subluxation was defined as an instability event not requiring manual reduction. Overhead athletes were defined as those who participated in sports involving lifting above one's head or utilizing a throwing arc of motion, and these included baseball, softball, basketball, football, quarterback position, CrossFit athletes, volleyball players, martial artists, rock climbers, gymnastics, water polo players, lacrosse players, frisbee players, and swimmers. And lastly, labral tear location was defined using the clock face method. So charts were reviewed for patients' clinical data, injury and imaging characteristics, and information on recurrent instability and revision surgery rates. patients were contacted via a survey to collect patient-reported outcomes, as well as information on returning to sports or work. The primary outcome of interest was recurring instability and revision surgery rates, and secondary outcomes were patient-reported outcomes and return to work or sports rates. A total of 256 patients were included with mean age of 23 years. 70% were non-overhead athletes. Our results showed that non-overhead athletes were more likely than overhead athletes to present following a dislocation, yet no differences were found in other injury characteristics, included presence of bony injury, labral tear size, posterior superior concomitant pathology. Further results showed that overhead athletes were more likely to undergo arthroscopic procedures as opposed to open procedures, and no differences were found in preoperative range of motion, strength, or intraoperative characteristics, such as the total number of anchors used or incidence of slap tear repair between the two groups. After survey administration, data on 60 patients with mean follow-up of 6.7 years was available. No difference was found between groups in primary outcomes of redislocation rate or revision stabilization. Additionally, no differences were found in secondary outcomes of interest, including patient-reported outcomes like the ASCS score, WOSI score, Brophy score, and SSV scores. No difference was found, lastly, when comparing return to work or sport rates between the groups. So in all, overhead athletes were more likely to have milder presentations with subluxation events, but no difference in outcomes were found when compared to non-overhead or contact sport athletes following surgery for first-time anterior instability episodes. And based on the results of our study, we've concluded that overhead athletes can be considered in the same treatment pathway as non-overhead athletes following first-time anterior shoulder instability episodes with similar outcomes expected. Thank you.
Thank you, Dr. Herman, for the informative study. We'll now turn to Dr. Bhargavi Maheshwer from University Hospital Cleveland Medical Center, who's going to discuss predictors of ACL ligament re-injury and return to sports in adolescent athletes, increased risk in younger age and earlier time to return to sport. Dr. Maheshwer.
Thank you, everyone. Thank you, Dr. Jacobs. My name is Bhargavi Maheshwer. I'm a PGY5 at Case Western Reserve University in Cleveland, Ohio. And today I'll be talking about predictive anterior cruciate return to sport in adolescent athletes. So ACL injuries are increasing in incidence in adolescent athletes specifically, and this is largely due to early participation in sports, as well as increased injury awareness. And this can have a devastating impact on future athlete performance, as up to 14% of young patients with ACL tears do not return to sport. And this is important because demographics and variables associated with ACL injury remain largely unknown, and the risk for secondary ACL injury is often greatest in the early return to sport period. And there's an overall lack of literature investigating the impact of type of sport played, as well as the mechanism of injury on primary and recurrent ACL tears, as well as the surgical management amongst high school athletes. So the purpose of our study was to characterize the epidemiologic trends of ACL injuries and secondary tear rates in high school athletes specifically, as well as to determine variables associated with sustaining a secondary ACL injury, which we defined as a contralateral ACL tear or primary ACL graft failure. So we looked at a prospective database over the course of 5 years with patients who had greater than 2-year follow-up. And we looked at various demographic variables, including age, physeal status, sex, race, body mass index, and school grade, as well as various sport and surgical variables, including primary sport, mechanism of injury, and if there was a secondary injury, graft type used in the primary ACL reconstruction, the time to return to sport, the number of physical therapy visits, as well as the total duration of follow-up. So we looked at students who had ACL injuries between the ages of 13 and 18, and we had 431 patients who participated in a high school sporting activity. And 344 of these patients did not have a secondary ACL injury, and 87 patients did have a secondary ACL injury, which was further broken down into 39 patients with graft failure and 48 patients with a contralateral ACL injury. And when looking at the sports played by these athletes, we saw that football, basketball, and soccer made up roughly 50% of our patient cohort. And when looking at results as a whole, we saw that patients with a secondary ACL injury were significantly younger in age, And looking at the graft failure patients, they had less physical therapy visits and had 14 months from their initial ACL reconstruction to their primary graft failure. And looking at patients with a contralateral ACL injury, we saw that there was 19 months from their index ACL reconstruction to their contralateral ACL injury. And when looking at these subgroups specifically, we saw that there was no significant difference in sex, BMI, and time to return to sport between those that sustained a graft failure and those who sustained a contralateral ACL injury. And when performing a multivariate regression to look at predictors associated with increased rate of ACL graft failure and contralateral ACL injury, we saw that the age at the time of primary ACL reconstruction, as well as the time to return to sport, were significantly associated with increased rate of primary ACL graft failures. Then we also saw that the age at the time of primary ACL reconstruction was associated with the increased rate of contralateral ACL injury. And we found that as age at the time of primary ACL reconstruction increased by 1 year, the rate of secondary ACL injury decreased by 27%. As well as a 1-month delay in return to sport was associated with the rate of secondary ACL injury decreasing by 13%. So thus, a younger age at the time of the primary ACL reconstruction, as well as a shorter time to return to sport, were significantly associated with an increased rate of secondary ACL injury. Some limitations for our study is that this is a single institution study, which limits the generalizability of our results to other institutions. There are differences in level of play between freshman, varsity, and junior varsity athletes, as well as the intensity that they play these sports that could confound our results, as well as the documentation of physical therapy that did vary, as some students did complete their physical therapy at outside institutions that we were not able to capture in our database. So in conclusion, the younger age and decreased time to return to sport following index ACL injury are significantly associated with sustaining a secondary ACL injury in the high school athlete population. And the counseling of young adolescent athletes, as well as their parents, should allow for the adequate rehabilitation and time to return to sport. And next steps for us include further studies to determine and optimize development of specific return to sport protocols for these unique athletes and the timelines applicable to them. These are my references. Happy to take questions at the end. Thank you.
Thank you very much for an interesting presentation. We'll turn now to Dr. Grant Schroeder from Stanford, who's going to discuss shorter relative patellar defect length and bone patellar tendon bone anterior cruciate ligament reconstruction is associated with better postoperative patient-reported outcomes at 1-year follow-up. Dr. Schroeder.
All right. Thank you very much to the OREF for having me. I'm a PGY4 at Stanford, and I'm excited to share some results of this study. So here we were talking about BTB ACL reconstruction, particularly the size of the patellar bony defect from the patellar graft harvest site. So as a little bit of background, a lot of us like BTB for its strength, bone-to-bone healing, high rates of return to play for athletes, and many consider it to be the gold standard for ACL reconstruction in high activity individuals. But what we don't like, and what we do know, is that anterior knee pain is a particular drawback to BTB ACL reconstruction. So the impetus for this study was really looking at some postoperative MRIs, and you can see on the right here that there can be some pretty prominent size of the patellar graft at 6 weeks, and some of them actually remodel quite miraculously, some maybe not as much, but we really just asked the question, is the initial size of this patellar bone defect or the bony remodeling within the first year associated with patient-reported outcomes? And our hypothesis being that larger bone defects at the time of surgery and those with larger residual defects at 1 year would be associated with worse outcomes. So this was a cohort study. We had 23 patients who were able to get knee MRIs at 6 weeks and 1 year postoperatively, as well as fill out KOOS scores at those intervals. And these were patients who had undergone BTB ACL reconstruction by one of 7 surgeons from 2 large academic institutions. We made the measurements that are pictured here. We measured the width, depth, and length of the defect as well as the patella so that we could come up with a relative defect measurement to make comparisons among people with different size patellas, and then looked at to see if there were any associations between these and patient-reported outcomes as evidenced by KOOS score differences. So for example, the E here shown in panel C is the length of the defect and F is the length of the pole-to-pole length of the patella, so that E divided by F would be the relative defect length, for example. So starting with just some basic morphological findings, we found that over a time between 6 weeks and 1 year, that the patellar defect width and depth decreased, sort of filled in, as you can see in these MRI images, but the length did not change between 6 weeks and 1 year. Here's really the meat of the material, which I find very interesting. So we found that a shorter relative defect length at 6 weeks, which is essentially a surrogate for the size of the defect at the time of surgery, because it can be seen very clearly at 6 weeks, was associated with better KOOS scores at 1 year in the KOOS subscales of pain, activities of daily living, function, sports and recreation, knee-related quality of life. So you can see in these panels on the right, these are all these different subsections of the KOOS score. As you increase the relative defect length as measured at 6 weeks post-operatively, the KOOS score, there's a significant association for decreasing the KOOS score. The only other category that did not reach significance regarding this relative defect length was symptoms, and that was because everybody had passed with regard to symptoms. There were no other associations, absolute or relative, at either 6 weeks or 1 year. The only other one was that a larger absolute defect depth at 1 year was associated with worse KOOS scores in the pain category. But the main takeaway here was really that this shorter relative defect length was associated with worse, or sorry, short is better as far as KOOS scores go. Looking at this slightly differently, we looked at, okay, did you meet a certain threshold to pass in this KOOS category? So here's showing pain versus sports and rec. So people who had passed, in fact, did have a shorter relative defect length, a 12% shorter relative defect length at 6 weeks compared to people who did not pass. And that was 14% for the sports and rec. So as the example shown here on the right, this is a patient with a relative defect length of 0.52 compared to a patient with a longer relative defect length of 0.61. You can see it's about the same patellar defect size of 23 millimeters, but it's a much different size of the patella. This is a 44 millimeter patella on the top compared to 37 on the bottom. We did an ROC analysis to try to determine a cut point. The ROC analysis sort of produced cut points that if it were above these values seen on the top right here, that you were unlikely to reach past thresholds. We then assigned a cut point of our own because we were more interested in increasing the specificity of this so that we could say with high confidence that if you're less than this, you will meet your past thresholds. And for that cut point, 0.5 worked out to be a very clinically tangible cut point where the vast majority of patients passed if their relative defect length was less than this compared to a much lower percentage if it was above. So again, if you look at comparing patients with a relative defect length less than 0.5 versus more than 0.5 for all categories, they had better outcomes for patients with defect lengths less than 0.5. And sports and rec and quality of life were able to reach statistical significance. So in conclusion, the main finding from this study was that a shorter relative defect length at 6 weeks post-surgery was associated with better KOOS scores at 1 year post-operatively. This is the image on the right here. So the main takeaway here is this ratio of the length, and we found that shorter relative length was associated with better KOOS scores. In the particular question of kneeling pain, it also held up in that regard that patients with longer relative defects reported more difficulty with kneeling. And then we identified a possible surgical target of less than 50% of the pole-to-pole patella length so that you can have high confidence that will likely meet past thresholds, at least in our sample. And then the only other statistical significant finding was that a larger absolute defect depth at 1 year was also associated with worse KOOS pain. So perhaps that lends evidence towards trying to fill in the defect as much as possible. And there's a lot of techniques for bone grafting, et cetera. As far as limitations of this paper go, it's a small sample size. That being said, we did find this a strong association, and we can't causally determine, again, that this is without, doing a randomized type trial. But it really makes me excited about future directions. I think this really opens the door for multiple areas of future study, obviously using a larger sample size. The question of what's the minimum bone block length for fixation, we know we have to have at least some bone block length to have purchase, but there are some cadaveric as well as porcine studies reporting perhaps you only need a 10 millimeter bone block compared to about the 20, which is commonly used. And then what is really the mechanism of pain? And there's some studies looking at how you can redistribute strain after taking out the central aspect of the patella, and perhaps it's this redistribution of strain that is causing ongoing pain at 1 year. With that, I would like to thank all my co-authors, and I'm looking forward to discussion and questions in a few minutes. Thank you.
Thank you very much, Schroeder. Excellent presentation. The final presentation in this session will be given by Dr. Sreetha Sidharthan from the Hospital for Special Surgery in New York, who will discuss reverse anatomical front and back reconstruction for volar intercalated segment instability, a non-dissociative, a biomechanical study. Dr. Sidharthan.
You're muted.
Everyone hear me?
Now we
see
can
the slides?
see the slides. Go for it.
Thank you. Good evening, everyone. Thank you, Dr. Jacobs, for the introduction. My name is Sreetha. I'm a PGY5 here at HSS. I'll be presenting today on reverse anafab to treat traumatic syn volar. So there's a lot of terminology surrounding wrist instability, some of which continues to be a little controversial. So I wanted to start off by laying out a few definitions. Carpal instability non-dissociative is actually a spectrum of conditions in which the individual bones of the distal and proximal carpal rows remain intact, but there's dysfunction of the proximal carpal row, often characterized by a clinical clunk. One of the 4 subcategories of syn is called syn volar. In syn volar, the proximal row rotates into flexion, which causes an associated palmar translation of the distal carpal row. Patients with symptomatic syn volar have a painful clunk as the proximal row pops from the flexed posture into an extended posture. In clinic, this can be produced with the classic mid-carpal shift test, in which the examiner translates the distal carpal row and brings the wrist into ulnar deviation, causing the proximal row to pop or clunk into extension. Unfortunately, surgical options are limited for these patients and include soft tissue procedures such as capsular plication. Bony procedures include limited mid-carpal fusions, which can limit carpal motion, a matter of concern for predominantly young and active patient population. So what causes syn volar? In a prior study by Shiga and colleagues, they showed that selective sectioning of the ulnar arm of the arcuate ligament, the dorsal radiocarpal ligament, the STT ligament, and the SC ligaments in a cadaveric model creates a reproducible model for syn volar. Like a boat at mooring, the loss of these critical volar and dorsal ligament stabilizers leads to proximal row instability. In this study, we propose a reverse anatomic front and back technique using a synthetic tape that's weaved through the carpus in order to reconstruct the affected ligaments. And this technique is conceptualized based off the known anafab reconstruction that's used for scapholunate dissociation. The aims of our study were to create syn volar in a biomechanical model using the concept set out by Shiga and colleagues, and then use this reverse anafab technique to reconstruct the affected ligaments. And we hypothesized that reverse anafab would restore normal wrist kinematics by reducing lunate flexion, capitate translation, and mid-carpal shift. 7 specimens were needed to detect a 10-degree difference in radial lunate angle with 80% power and 95% confidence. And the exclusion criteria listed here, including radiographic evidence of baseline OA or carpal malalignment of the wrist in the cadavers. So our jig and setup is pictured here, and I just want to highlight a few of the key components, one of which is an actuator which applies a palmarly directed load through a screw in the distal carpal row and primarily through the capitate. And then we have a load cell that measures this force applied to the distal carpal row. Fluoroscopy is then used to measure lunate rotation and capitate translation at 40 newtons of load application. Here we can see in the intact specimen, we can see some lunate flexion and capitate displacement with palmarly directed load. And then in the Synvesi specimen, after ligament sectioning, the lunate flexion and capitate translation dramatically increases. And then after reverse anafab reconstruction, we're able to restore lunate flexion and capitate displacement. All 7 specimens we tested had a positive midcarpal clunk after the ligaments were sectioned, and reverse anafab eliminated the clunk. These are the cumulative results from all 7 specimens with regards to radial lunate angle. On the y-axis, we have radial lunate angle, where negative values represent lunate flexion and positive represents lunate extension, and each of the lines is a single specimen. Lunate flexion increased by a mean of 17 degrees after ligament sectioning, and decreased by a mean of 27 degrees after reverse anafab reconstruction, and this was found to be statistically significant. Similarly, capitate displacement increased by a mean of 5 millimeters after ligament sectioning, and decreased by 6 millimeters after reconstruction. In conclusion, our data suggests that reverse anafab can successfully eliminate midcarpal clunk and proximal road kinematic dysfunction associated with synvolar in a cadaveric model. And this may offer another surgical option for the young active patient with synvolar and maintained cartilage who is reluctant to undergo arthrodesis. I especially want to say a big thanks to Dr. Wolf, who took me on as a mentee for this study, and to Kate, our engineer in our lab, who put up with me with some long days in the lab. Thank you.
Thank you very much. Intriguing and elegant presentation. Okay, we're a little behind schedule again, but we have a few minutes for discussion. So I'll turn to our judges. I first see Andy Pollock. Andy, you're on mute. Well, how about you, Brian? Why don't we start with you, Brian? You're not
Okay. This is for Dr. Araujo, I'm sorry if I mispronounced your name. So besides orthopedic surgeons, how about interventional radiologists or another group of surgeons, which has actually a fairly large female population? How do orthopedic surgeons compare to that group in terms of incidence of breast cancer and potentially also exposure to the lateral aspect of the breast, not necessarily covered by the lead vests that we use?
Yes, sir. That's a great point. We really did try to find studies that looked at their exposure as well as like X-ray technicians and other just general people working with radiation. It was really difficult to find studies that commented on their rates of breast cancer in comparison to surgical specialties, but that's something that we do want to look into more, particularly if we're able to kind of work with the College of Radiology regarding updated guidelines, and we imagine that they would have some data in that regard. Yeah, but we were not able to find anything specific.
And then in terms of the orthopedic surgeons, was there enough granularity to look at like a hand surgeon versus like a trauma surgeon versus a spine surgeon?
The one paper that kind of parsed that out was really quantifying by procedure, which I guess you could extrapolate to say like a trauma surgeon that does these procedures would have this, but there wasn't a study that broke down the reported results by specialist, by specialty type. However, they did break it down by procedure type, so I guess that could just be extrapolated.
Thank you. Dr. Pollock.
Yes, sorry about that technical difficulty before. For Dr. Maheshwer, were you able, it was a great presentation, great paper. You showed that for every 1 month delay in return to sport, the risk of secondary ACL injury decreased. Was there a ceiling effect on that? Is there in other words, at what level can you say there's no increased safety by waiting longer?
Yeah, so the statistical model essentially showed a plateau or the ceiling effect kind of right around the 4-year mark. Obviously, it was very unrealistic, and the reality of kind of interpreting the data being that no child is going to ever wait that long to go back to a sport. But really, the 1 month findings that we were kind of able to extract or see was that was really valuable alone in just kind of counseling patients, and not even just the patients, the parents, to really help them understand, since we see more and more of these year-round athletes, and the especially in sports specialization, it's something that even just a couple months that they could wait could have a profound effect, and this kind of quantifies that for patients who can kind of grasp that number a little bit better.
So what's the rule of thumb that your group uses now then to determine when to let them go back?
So we have within our institution, they'll go through physical therapy and have kind of physical therapy testing that they'll do. And we didn't have enough of that data since some people went outside of our system to get that. But roughly it's roughly kind of averages out to be 9 or 10 months that we kind of give patients that clearance to return to sport, which is likely similar to other providers.
Thank you.
Go ahead, Dr. Silva. Do you have a question?
Yeah, I have a question for Dr. Schroeder. I think you touched on this a little bit. Could you elaborate on what do you think the basis is for the I guess the poor outcomes in the longer defects? Is it biomechanical, or is it strictly like a wound size effect? Could you
Absolutely,
elaborate?
yeah. Thank you for that question, Dr. Silva. So there's a study that looks at how strain is redistributed after a BTB defect site is created. And the authors of that study looked at, does the shape of the proximal portion of the wedge make a difference? So if that's rounded, if that is pointed versus a traditional box cut. And what they found was that it didn't, any of those three things that they were testing in that study, it actually didn't matter, but all of them did substantially redistribute strain to be further away from the midline and more laterally. What they didn't look at, though, was how does the length affect things? And so I think given these findings, a logical area of future study would be repeat that same study where you're measuring strain on the anterior surface of the patella, but instead of changing the shape, you're really just changing the length, because that's what we found out to be the significant finding here.
Yeah,
Thank
great
you.
idea for follow-up. Thanks.
Did you want a follow-up question?
No.
Okay, so I'll ask Dr. Sidharthan a question. Rapidly get over my skis, however, as a joint surgeon, but I'll give it a shot. First of all, I thought it was an elegant biomechanical study on this pattern of malrotation in the wrist. You mentioned repair with synthetic tape, and that caught my interest. What do we know about this? Is this intended? Is this a biodegradable material? Is it one that has a scaffolding? The idea being that soft tissue grows in. How stable might this be if this is used for reconstruction? Can you give us some insight into this material? You're on mute.
You're on mute.
Sorry. So this is a labral tape that's used for the repair. And I would say that, it's used very commonly in sports and also used in wrist and foot and ankle. From the carpal standpoint, our reverse anafab reconstruction is modeled off the anafab reconstruction, which is used for scapholunate dissociation. And usually we'll kind of augment that repair with biological, so using some sort of tendon reconstruction in addition to it. For the purposes of our biomechanical testing, we decided not to do that, but in the clinical setting, we would augment this with likely ECRB tendon as well. With regards to the long-term effects, in terms of anafab, we know, and we can kind of postulate that hopefully the results would kind of clinical results would relay to the reverse anafab. The anafab results have 1 to 2 year postoperative outcomes that have been published in the literature. And we're seeing good general outcomes from the biomechanics standpoint with these patients. And the idea is that, especially with some immobilization, that soft tissue will also help augment the repair of the suture tape and the labral tape.
Thanks very much. Any other questions? I do have one for Dr. Herman. Don't want to leave him out. How much surgical technique heterogeneity was there in this comparison? And there's a variety of ways to do both open and arthroscopic surgery for anterior instability. Can you discuss that and did this have any impact on the outcomes?
Yeah, sure. So technically, I think we did see, not by a lot, but there was a statistical difference in the amount of open repairs in the contact athletes as opposed to the um, arthroscopic repairs. And well, the difference in open repairs between the two groups. I think you can argue that you'd be a little more hesitant to do an open repair in a thrower or an overhead athlete who is using the external rotation and somewhat of the laxity to their advantage when it comes to a throwing sport. So I think that's probably one of the reasons for a difference. And I don't think we saw a statistical difference in necessarily the degree of pathology following just the first time of dislocation. So you could argue that if there's a need for a bony procedure, maybe if the contact athlete has a more severe, if the contact athlete's more likely to present with a dislocation, has some more severe injury with bone loss, or things like that need a bony procedure, although it's probably rare for the first time, that could be another reason for open procedure. But within each open versus arthroscopic, within each type, I don't think there's a technical difference. I think you always worry with an overhead athlete about tightening them too much. Like I said, losing that advantage that they have, but otherwise, no.
And one follow-up question, does this pathology have anything to do with the chronic underperformance of the Pittsburgh Pirates? As a
Well,
Cub
thank
fan,
you.
I just couldn't
I
resist
think
the question. You don't have to.
we've been looking for some sort of reason they've been underperforming for the 31 years I've lived in Pittsburgh. So
That's as good as any reason, right? So
yeah, that's right. We're just looking for something.
All right. With that, we want to thank all the presenters from session 2, some outstanding papers. Thank you very much. I want to remind the judges and presenters to complete the scoring survey for session 2 at this time. And before we take our next break, Lee Grossman is back to introduce a message from Dr. John Callahan, who has recorded this to tell us about a wonderful way to support OREF through an estate gift. Lee?
Well, as a lifelong Pirates fan, that was brutal, Josh. But I'll get over it because I've had to every year. Thank you for introducing this video, Dr. Jacobs. OREF has an exciting program for donors who would like to include OREF in their estate plans. Dr. John Callahan and his wife, Kim, have been extremely generous to OREF. And in this short video, Dr. Callahan is going to talk briefly about why he and his wife support OREF and about this giving program. Thank you.
Hey, my name is John Callahan. I'm a retired hip and knee surgeon who, after serving in the Army and practicing at Duke University for 2 years, practiced at the University of Iowa for the remainder of my entire 34-year career. During my career, I had the privilege of leading a number of orthopedic organizations, including the American Academy of Orthopedic Surgeons and the Orthopaedic Research and Education Foundation. Kim, my wife of 39 years, and I strongly believe in the mission of OREF to fund and facilitate outstanding research and mentor researchers to improve the lives of patients with musculoskeletal conditions. As a multiple recipient of OREF research support, my research team and I benefited from the generosity of charitable gifts to OREF, my orthopedic colleagues, and their families. Being a recipient of an OREF career development grant led me to a research career that included over 20 years of NIH funding. I personally know the importance and value of OREF funding and its impact in advancing our specialty and providing care to our patients with musculoskeletal conditions. OREF is establishing a new recognition society for donors who make an unrestricted deferred gift to OREF as part of a will or living trust. Kim and I have contributed to OREF for more than 35 years, including a $1 million unrestricted deferred gift. We encourage you to become members of the new John and Kim Callahan Legacy Society by joining Kim and me in making an unrestricted deferred gift to OREF as part of a will or living trust. You will hear more details about the new effort in the new year. Thank you for considering this new opportunity to further help OREF with its mission that is so relevant and important to our practice of orthopedic surgery now and in the future.
Thanks for that important message from Dr. Callahan. It's a great time of year to consider including OREF in your estate planning. If you'd like more information about the John and Kim Callahan Legacy Society, please visit the OREF website. Now we'll take a short break before we begin the final session of the evening. We will resume at 7:16 Central Time. Thank you. Hey, welcome back. The 2025 OREF National Resident Research Symposium. We're ready to start the third and final session presenter. Our first presenter in this session will be Alexander White from the Hospital for Special Surgery, who's going to discuss the effect of posterior tibial slope on tibiofemoral joint biomechanics and in vitro analysis. Dr. White.
Okay, can you guys hear me?
Perfect.
Great. So good evening, and thank you for the opportunity to present today. My authors and I have no relevant disclosures. So the incidence of ACL reconstruction has more than doubled over the last several decades. Despite this, failure rates have remained stubbornly high. Increased posterior tibial slope has been identified as one anatomic risk factor for both primary ACL failure and ACL reconstruction failure. And several studies have demonstrated that high posterior tibial slope increases forces across the ACL and increases anterior tibial translation. Slope-reducing osteotomies have gained popularity as a sagittal plane correction to reduce the risk of ACL failure in the appropriate patient. And while most of these procedures are performed in the revision setting, some surgeons are performing them as part of their primary operation. While there's limited canine literature and mixed human studies on tibiofemoral contact mechanics after slope-changing osteotomies, based on our review, no study has investigated both medial and lateral compartment tibiofemoral contact mechanics after pure sagittal plane osteotomies. And so with that, the purpose of our study was to quantify the effects of increased and decreased posterior tibial slope on tibial plateau contact mechanics using human cadaveric knees with an intact ACL during knee flexion with axial loads. And so informed by our pilot studies, we hypothesized that increased posterior tibial slope would result in a posterior translation of the weighted center of contact on the tibia in the lateral compartment, whereas decreased posterior tibial slope would result in an anterior translation of the weighted center of contact in the lateral compartment. We also hypothesized that peak contact stresses would remain unchanged for both conditions. And so our study included 9 human cadaveric knees with intact cruciate and collateral ligaments. We tested 3 conditions: an intact state, a 7-degree increased slope condition, and a 7-degree decreased slope condition. Osteotomies were performed using a freehand supratubical technique and were fixed using bone staples. The increased slope condition was kept open using a 7-degree cement wedge, and specimens were included if they had a native tibial slope in the range of 7 to 11 degrees. The knees were potted in custom fixtures, and a TechScan pressure sensor was attached across the tibial plateau. For testing, the knees were mounted to the AMTI Vivo joint simulator, and the testing protocol was performed uniformly for each condition and consisted of 500 newtons of axial compression at 0, 15, 30, and 45 degrees of knee flexion. All outcomes were quantified for each compartment and consisted of a tibial weighted center of contact and peak contact stress as measured through the TechScan sensor, which you can see depicted here. And so as far as results, the following table demonstrates the anterior and posterior translation of the weighted center of contact for each slope condition compared to the intact state. The most immediate takeaway is that the greatest magnitude of anterior posterior change occurs in the lateral compartment for both slope conditions. At all tested flexion angles, the decreased slope condition produced a significant anterior shift in the center of contact in the lateral compartment compared to the increased slope condition. You can see these findings represented differently in the following pressure map, which averages the changes across the various slope conditions, showing a clear increase in anterior to posterior translation in the lateral compartment relative to the mostly static medial compartment changes. And so when we look at changes in the peak contact stresses under axial loading, significant differences were noted at 30 and 45 degrees of knee flexion in the lateral compartment, where pressures were greater in the decreased slope condition compared to increased slope. So in conclusion, we found that decreased tibial slope was associated with an anterior translation of the weighted center of contact in the lateral compartment at all flexion angles. Additionally, we found a significant increase in peak contact stresses in the lateral compartment alone at 30 and 45 degrees of knee flexion in the decreased slope condition. And then finally, medial compartment contact pressures and contact points were unchanged for all conditions. And so in summary, shifts in the weighted center of contact are biased to the lateral compartment of the knee. This finding may be in part explained by the geometric differences of the two compartments and the reduced internal tibial rotation that occurs at low slopes, as demonstrated in a recent computational modeling study, actually from our institution. Additionally, with the unacceptably high incidence of post-traumatic OA following ACL reconstruction, large shifts in the weighted center of contact should be investigated further to explore the long-term implications of this procedure at the joint level. And so thank you to REF and everybody for listening tonight. Thank you.
Thank you very much for that excellent presentation. We'll now turn to Dr. Erik Nakken from the University of Michigan, who's going to discuss optimizing contact pressures of the posterior heel during lower extremity immobilization of biomechanical study. Dr. Nakken.
Hello, everyone. My name is Erik, and the title of my talk is Optimizing Contact Pressures of the Posterior Heel During Lower Extremity Mobilization, a biomechanical study. Our team has no disclosures, and funding was provided by the University of Michigan and the AOFAS. So this is our problem today, posterior heel pressure injury. On the left, we have a healthy teenage female after a Liz Frank ORAF with stage 3 pressure ulcer from a splint. And on the right, we have a quadriplegic patient after bilateral Achilles lengthening with bilateral stage 1 pressure injury after, from a cam boot. So today we'll be discussing how to reduce contact pressure of the posterior heel while in a splint or a cam boot to aim to reduce the incidence of these pressure injuries. But how big is this problem? Well, pressure injuries cost over $11 billion annually in the United States and are the second highest healthcare claim. Splint-induced pressure injury is the second most common iatrogenic plastic surgery referral, and the incidence of complications related to prefabricated pneumatic braces, such as cam boots, increased the most of all immobilization devices during a prior 5-year study period. We know that dermal, arterial, or capillaries collapse with pressure greater than 32 millimeters of mercury, and remember this important threshold. Ulcer formation can occur after only 2 to 6 hours of contact pressure, but patients are obviously in a splint or a cam boot much longer than 2 to 6 hours. There are multiple risk factors for pressure injury listed here on the right. Those we most commonly encounter in orthopedic surgery are neuropathy and postoperative nerve blocks. This led to our research questions. Can simple changes in splinting technique reduce posterior heel contact pressure? This pertains to variables such as padding thickness, type, or heel position, such as floating the heel. And can this be applied to cam boots? No studies yet exist on these topics. Here are our methods. We tested 20 legs in 10 patients without foot or ankle injury. A pressure transducer was applied over the posterior heel as seen on the right, and they were splinted in the usual fashion. We used 2 different brands of padding, Witex, which is thinner, you may refer to it also as Webril, versus Specialist, which is a little bit thicker, and tested contact pressure with 0, 2, 4, 6, 8, and 10 layers of padding, both with the heel resting down and the heel floating. We also tested heel down and heel floating in a cam boot, and pressure measurements were compared to 32 millimeters of mercury, the pressure of dermal, arterial, or capillary collapse. Let's look first at our results in a splint. Floating the heel as seen on the right in B rather than resting it down in A was the most important tested variable, and we'll see why in the graph on the next slide. The average contact pressure of the heel was above the important threshold of 32 millimeters of mercury when the heel was resting down. This is seen in the blue or the top line of the graph, regardless of padding thickness applied. The average decreased below 32 when floating the heel for 8 and 10 layers of padding. On this graph, we also see the effect of padding brand. The top 2 lines are heel down, the bottom 2 are heel floating. The lower of the 2 lines in each group is specialist brand padding, which outperformed Witex. 6, 8, and 10 layers of specialist padding were at or below 32, while 8 and 10 layers of Witex padding were at or below 32. One additional finding, a few times during the study, there was a sudden spike in pressure measurement that did not make sense or follow the general pressure trend. After removal of the extremity from the splint, it could be seen that the padding in the posterior heel had bunched up, like in the image on the right, causing a spike in pressure. In the graph on the left, the blue bars represent bunch padding, and the repeat measurement with evenly applied padding is shown on the right in magenta. Bunched undercast padding can increase the peak contact pressure by about 2 to 6-fold, with an average of 3 times the contact pressure. Now on to our cam boot findings. Here we have a graph of our overall data. We have a large outlier in subject 11, so let's look at the graph a little closer without this measurement. The blue dash bars on the left are the pressure with the heel resting down, and the right is in green is with the heel floating. Note that all legs with the heel resting down are over 32. With the heel down, no legs were under 32, similar to in a splint, and the average pressure was 85. With the heel floating, 55% of legs were under 32, with an average pressure of 40. And 55% sure sounds good, but ladies and gentlemen, let's remember if we're in school, that gets an F. Additionally, the average for floating the heel was 40, which is above the 32 threshold. Floating the heel is helpful to reduce contact pressure by over 50%, but this alone may not be enough. So here are conclusions and keys to victory. If you remember anything, remember to float the heel, float the heel, float the heel, both in a splint and a cam boot. We recommend applying 8 to 10 layers of padding behind the heel for either brand of padding. And education on this topic is critical regarding heel floating, positioning, thickness, and type to reduce heel contact pressure. And also beware of bunch padding. Put on your padding carefully when applying a splint. This can cause a 3-fold spike in pressure. And more on cam boots, we don't recommend sleeping or prolonged use without frequent skin checks, and beware of prolonged use, especially in a patient with sensory deficits. Thank you, and go blue.
Thanks so much, Dr. Nakken. Unique study. I appreciate it. The next study is by Dr. Mathangi Sridharan from the University of California, Los Angeles. Dr. Sridharan is going to discuss predictive factors of having a second UBC-related pathological.
Hi, my name is Mathangi. I'm a PGY3 at UCLA. I'll be presenting today on repeat pathologic fracture after conservative treatment of unicameral bone cysts. So starting with some background information on UBCs, I think we all know there's very limited consensus on when to surgically manage UBCs. Pathologic fractures of these simple bone cysts are typically treated with conservative management the first time, especially in the upper extremity. Here we have just a couple representative pictures of unicameral bone cysts, the one on the left side of the screen in the humerus demonstrating that classic fallen leaf sign indicating a pathologic fracture. And the one on that right showing one in the femoral neck, not fractured, but definitely showing how much these can weaken host bone integrity. Overall, though, there's also an inconsistent rate of spontaneous healing in pathologic fractures without surgery. And this is important because conservative management is usually done with the hope that the cyst will heal itself. So we set out to ask the question, who might have a repeat UBC-related pathologic fracture in an effort to guide whether to intervene on these a little bit earlier? So we looked at a consecutive series of all patients with unicameral bone cyst at our institution over a period of several years from 2012 to 2025. We are a tertiary referral center, so we do end up seeing a lot of these for our oncology surgeons. We looked at a variety of demographic variables, clinical factors, and whether they had a pathologic fracture at presentation. And we also did a radiographic review looking at skeletal maturity, bone location, trying to characterize the cyst in terms of bone width, whether it involved the cortices, and its location relative to the physis, because this study utilized a lot of pediatric patients. We only included patients that had at least 6 months of follow-up with an orthopedic oncologist. And our primary outcomes were repeat pathologic fracture after conservative management, and secondarily, just looking at who underwent surgical fixation for any reason. We were able to include almost 180 patients, and unsurprisingly, given that we're looking at UBCs, the average age was pediatric, about 16 years, with a pretty wide variance. Most patients had minimal to moderate pain, and cysts were actually most commonly in the proximal humerus. Again, this is pretty common for UBCs. Most cysts had cortical involvement, and most cysts were most of the bone width greater than 2/3. And in skeletally immature patients, cysts were on average about 3 centimeters from the nearest physis. Of our entire cohort, a lot of them, about 70%, presented with a pathologic fracture. A good amount of these patients were treated conservatively. And then of these, nearly a quarter of the patients that were treated conservatively had a repeat pathologic fracture. So a good amount are suffering from not healing and fracturing through it again. Of the 27 patients that had a repeat pathologic fracture, we noticed that the patients were significantly younger, about 7 years on average. Most of them were male, and nearly all of them were in the upper limb. This figure is just representing of those 27 patients that had a repeat pathologic fracture. Again, the main factors that seem to demonstrate some kind of association with having a repeat pathologic fracture. We also saw that 50% of the patients underwent surgical fixation for any reason in the cohort. And predictive factors of these were, interestingly, private insurance, having moderate to severe pain, or having a UBC in the femur, the last two being relatively unsurprising, especially given that femur UBCs, if they fracture, can be very devastating for the patients. So overall, we found that there was a specific clinical profile of patients that were more likely to have a repeat pathologic fracture after conservative management. These patients tend to be younger, tend to be male, and have cysts that are closer to the physis. Interestingly, we did notice that there's some role that insurance status has on impacting a clinical course and whether patients receive surgery, which was definitely interesting because at our institution, we are agnostic of insurance status, so this does warrant some further investigation. And our main takeaway here for our clinical practices was that orthopedic surgeons who treat these should consider early surgical fixation in patients with these specific clinical factors in order to prevent repeat injury, pain, immobilization, and factors associated with these types of repeat injuries. These are my works cited, and thank you so much for having me.
Thank you very much. Excellent presentation. Next presentation is by Dr. Nathan Varady from the Hospital for Special Surgery, who's going to discuss low complication rate following contemporary pure anteriorization tibial tubercle osteotomy for patellofemoral overload. Dr. Varady.
You are muted.
All right, we'll figure it out. Let's see.
You
guys still have, do you have me now?
I hear you, but we can't see your slides.
Okay. Figure this out.
No, okay.
We good?
You got to put it in presentation mode. You got it in.
First person to have this problem all night. Unbelievable.
You're the second.
If you go all the way up to the top.
Okay.
Right there. There you go.
All right. So
you're
thanks everyone for the chance to present. My name's Nathan. I'm going to be presenting on a pure anterizing tibial tubercle osteotomy technique. No disclosures related to this work. So there's been a recent explosion in the patellofemoral literature demonstrating that sagittal alignment is really critical to patellofemoral chondral wear. In particular, that a more posterior tibial tubercle relative to the trochlear groove, or negative sagittal TTTG, strongly increases patellofemoral chondral wear. And so as a result, as a result of this, if a patient has patellofemoral chondral wear, you often want to anteriorize them to prevent the development, to unload the chondral lesion. And in addition, sorry guys, I have my notes and I don't have them now. So anyway, so sagittal tibial, you have a negative sagittal TTG, increased chondral wear. And so there's often a need to anteriorize the tibial tubercle. The problem was that in historically pure anterizing tibial tubercle techniques were associated with really unacceptably high complication rates. So the full details of the McKay are kind of beyond the scope, but suffice it to say it was a coronal plane cut, a single uniplane cut in the coronal plane. You anteriorize 2 to 3 centimeters, iliac crest bone graft proximally. And as you can see on the image on the right, there wasn't a lot of bony contact, and non-union and wound complications were quite a big problem. So you might ask, well, why do we need to anteriorize at all? Can't we just anterior medialize? And there's no question that the Fulkerson is a fantastic operation. But what if your patient has a medial cartilage lesion? If you anterior medialize, you may be increasing the contact stresses across that medial lesion. And in addition, even a patient with a central cartilage lesion If their tibial tubercle trochlear group distance is normal and you medialize them, then you might actually be creating a non-anatomic mechanical environment in the patellofemoral joint. You might even increase medial patella instability. So there's often a need to just purely anteriorize if only we could do it safely. And so the purpose of this study was to develop and assess a novel peer-anterizing tibial tubercle osteotomy technique. The technique involves making an L cut in the axial plane. You anteriorize by about 10 to 15 millimeters, and then transfix this osteotomy with two 4.5 millimeter screws angled in the anterolateral to posterior medial direction. And as you can see on the image on the left, there's actually a fair amount of bony contact here. We don't need any bone graft in this technique. And so this study involved consecutive patients undergoing this style of osteotomy with minimum 6-month follow-up. And this time period for follow-up was chosen because really what we're focused on is the complication rate, since this is really what has led traditional anteriorizing TTO techniques to fall out of favor. And in particular, we really were cared about non-union and fracture, and wound complications. And all three of those, especially non-union and the wound complication, either both the wound is either healed, the bone is either healed, or it hasn't by that 6-month time point. And then in addition, among the subset of patients who had reached at least 2-year follow-up, we also looked at improvements and functional outcomes. So we had 57 patients, average age was about 30, 54% of whom were women. Had an average follow-up of 2.4 years, had 100% follow-up at that 6-month time point for our primary outcomes of complications. We anteriorized by about 11 millimeters, and 70% of patients underwent a concomitant cartilage restoration procedure with their osteotomy, but 30% of people actually had this as an isolated treatment for their chondral wear. And the most important finding of this study was that there was an overall very low complication rate at about 5%. And this included 2 manipulations under anesthesia and 1 superficial cellulitis that was managed with oral antibiotics. And these compare quite favorably to other types of TTOs in the literature, such as distalization or anterior medialization. No episodes of wound dehiscence, deep surgical site infection, or non-union. And then in addition, among the 26 patients who had reached 2 years post-op, there were really positive, significant improvements in both IKDC improving 40 points and pain scores decreasing by 65%. But we didn't have complete, only about half our sample had reached 2-year follow-up, so these are still quite exploratory. So limitations of the study, non-randomized, causality cannot be certain, relatively short follow-up period. And then given these patients were really candidate for another type of osteotomy, it just would have been a cartilage restoration procedure alone. There wasn't really a relevant comparative group. The exciting thing is really the future question. So how much anteriorization is necessary? Is an anteriorizing TTO sufficient, or is a concomitant cartilage restoration procedure really necessary? And then really the most exciting for me is you have a patient with a negative sagittal TTGG. They have some patellofemoral pain, maybe a little MR signal in the trochlea, but they don't yet have a frank cartilage lesion. If we do an anteriorizing TTO on that patient, do we really change the natural history of that patellofemoral joint and prevent the development of patellofemoral arthritis that otherwise would have occurred, which would be pretty amazing. So in conclusion, contemporary peer anterizing TTO can be performed safely. We had no wound breakdowns or non-unions in our series. Among the subset of patients who did have outcomes, the patient-reported improvements were dramatic. And so I think moving forward with the growing recognition of sagittal TTTG, and the importance of sagittal alignment on patellofemoral chondral wear, this may be an increasingly important tool in surgeons' armamentarium for treating patients with patellofemoral pain who have essentially normal coronal plane alignment. So thank you and look forward to questions.
Thank you very much for that informative presentation. And our final presentation in this session will be given by Dr. Joshua Bram from the Hospital for Special Surgery, who's going to discuss skeletal age assessment from knee radiographs using deep learning. Dr. Bram.
Thank you for the opportunity to present. Just give me a second here. You see my slides?
Yeah, be better. There we go. You're good.
Awesome. All right. So I'd like to thank the opportunity to present. My name is, as Dr. Jacobs said, Josh Bram. I'm a PGY5 at HSS going into pediatric orthopedics. I'd like to thank my co-authors, including Dr. Fabricant, for this work. Our disclosures are that this was funded by an AOSSM Playmaker grant. Skeletal maturity assessment dictates appropriate surgical management for orthopedic surgeons who are routinely treating children to avoid the dreaded complication of iatrogenic physeal injury as seen on the right. The decision to perform a physeal-sparing ACL reconstruction or the timing of epiphysiodesis for leg length discrepancy is usually based specifically on skeletal or bone age which is determined using the Grulich-Pyle atlas from left-hand radiographs. However, this method is notably time-consuming with variable human-based inter-rater reliability, and it still necessitates additional radiation and healthcare expenditure. While a variety of estimation methods have been developed based on plain knee radiographs, such as the modified FELS and abbreviated FELS scoring out of the University Hospital in Cleveland, these suffer from variable reliability and clinical applicability. Deep learning, a branch of machine learning, has been successfully applied to orthopedics previously, particularly for arthroplasty implant recognition. And additionally, several prior studies have used deep learning for bone age estimation from hand radiographs, including a notable competition in 2017 out of the Radiological Society of North America. Earlier this year, we published a bone age model that was in AJSM, trained on over 20,000 hand radiographs from 3 diverse data sets that was accurate within 3.7 months of the ground truth bone age. But a reliable deep learning tool based on knee imaging is not currently available and would really represent a paradigm shift in the way orthopedic surgeons treat skeletally immature patients with knee injuries. And therefore, our primary aim was to develop a deep learning model for assessing bone age based on plain knee radiographs. All patients less than or equal to 18 years of age at our orthopedic specialty hospital between 2005 and 2024 who had both a paired hand film and a knee radiograph within 3 months of each other were identified. Patients with prior physeal trauma, genetic disorders, or other endocrinopathies that might affect skeletal maturation were excluded, and all images underwent a pretty extensive pre-processing pipeline beyond the scope of this talk. Our previously developed hand model was then used to assign the bone age for each knee image in the training set, which was determined using the patient's hand x-ray as well as sex and chronologic age. These, what we call pseudo labels, were then exclusively used to train our knee model, and while the final ground truth labels for the test set were assigned using the Grulich-Pyle atlas manually. A convex deep learning model was then trained using sex, the hand-based skeletal age from the paired image, and chronological age as inputs for estimation of bone age using 5-fold validation, and model performance was evaluated using mean absolute error and bland Altman plots. After application of our inclusion-exclusion criteria, a total of over 2,700 knees from 1,500 knee radiograph films obtained across 1,100 patients were included. 80% of images were used to train the model, and then 20% were used for a test set. Nearly 60% of the cohort was male with a mean chronological age of 13 years. As you can see on the right here, the model achieved an excellent mean absolute error of just over 5 months from the ground truth bone age that was assigned using the Grulich-Pyle atlas in the test set. This model also notably outperformed other prior simple classification methods using the knee in the literature, with approximately half of the mean absolute error that was determined using the abbreviated FELS method at 9.6 months. Perhaps to kind of make this a little more better illustrate our results, the scatter plot here demonstrates the model's predictions compared to the ground truth bone ages in the test set, highlighting very few deviations between the predicted and true values, providing a really clear assessment of the model's accuracy and reliability. And then additional bland Altman analysis on the right, I think you can see, indicates close agreement between predicted and ground truth bone ages. Last, we conducted separate interpretability analysis or saliency maps to kind of demonstrate where the model is focusing on to determine bone age. And I think, as you can see, particularly in the lateral radiographs, that this is focusing on the physes and the apophysis of the knee, as you would clinically. So in conclusion, we think this model really this study really reports on the successful development of the state-of-the-art deep learning model for determination of bone age from routinely available knee x-rays that achieves similar accuracy to expert orthopedic surgeons and radiologists and vastly outperforms other commonly available knee bone age methods in the literature. We think this has the real potential to eliminate the requirement for hand radiographs and associated extra radiation for those pediatric surgeons who are planning surgeries about the knee in skeletally immature patients, and also really will reduce the time required for bone age determination. Future models will include external validation at other centers, application to other modalities such as MRI, which is in progress, and then we're actually working with our institution to incorporate this into our picture archiving system to make it for easier application. Thank you very much for your time.
Thank you very much. Fascinating topic, great presentation. We have time for questions. I'll turn to our judges. Dr. Pollack.
Thanks. For Dr. Varady, the 2 complications that you reported requiring manipulation, was there any, what was the distribution of those between those with and without the concomitant cartilage restoration procedure?
It's a good question. They both were with the cartilage. Both were in the cartilage procedure, and the wound complication happened to be in someone who didn't have cartilage. It certainly could have been from the cartilage itself and not even the TTO.
Got it. Thank you.
Okay, Dr. Snyder.
So this is for Dr. Sidharthan. About 20 years ago, we showed that you can use a CT-based rigidity analysis. Actually, we got a Kappa Delta award for it because the issue really is in terms of fracture risk. It depends on the load capacity of the bone. And we showed that sort of your standard cyst parameters really are neither neither sensitive nor specific. Did you, and we've published that actually Musculoskeletal Tumor Society did a very large prospective study. Did you have an opportunity to look at any CT scans or advanced transaxial imaging on those patients?
No, I did not, truthfully. It was a clinical study done retrospectively, and at our institution, we aren't routinely getting CT or further 3D like imaging for these diagnoses. So unfortunately, I did not look into that. That is actually a very interesting take that I will bring up with our attendings, because I hadn't even thought about that for the study, truthfully.
Yeah, and with the bone MRI now, so most tumors often will get an MRI as just part of the workup of any benign or metastatic lesion or primary. So, and then with bone MRI, you can actually calculate that. So you may want to think about that.
Will do.
Dr. Silva? You're on mute. There you go.
Thanks, Josh. So for Dr. Nakken, so very interesting study. So does this change how your institution is going to recommend prescribing people to get the CAM boot versus getting CAS? Because it seems like the CAM boot brings with it some unintended side effects.
Yeah, I think because I have been working with the foot and ankle team on this study is they've talked about at least more frequently with their patients now is frequent removal for at least skin checks. Because the examples I showed of the pictures were our patients, and especially avoiding them now in people that are like paraplegics. And so I think they're just now more careful with more instructions. And also we've added this to our post-operative instructions for patients to either float the heel, check the skin, things like that, so that we can hopefully avoid some of these problems moving forward.
Great, thank you.
Thank you. I wanted to ask a question to Dr. White. You know, the focus of tibial slope has been on ACL injuries. What about the tibial slope impact on other ligamentous injuries of the knee, the posterior cruciates or the collaterals? What do we know about that?
Yeah, great question. I think as far as collaterals go, I'm not sure of any kind of association there. I know for PCL, I think historically they used to do a deflection osteotomy where they'd actually increase the slope, which makes sense. You'd think that, you know, the decreased slope reduces force on the ACL and actually increased slope reduces force on the PCL. Although it's obviously done less commonly as those are treated kind of non-operatively for the most part, unless it's, you know, a grade 3 injury. But yeah, I mean, I think the kind of crux of this study was that nobody's really looked at contact pressures in full with a slope reducing osteotomy, as this is a procedure that's done for, you know, to decrease the force on the ligaments. Whereas, as we know, obviously osteotomies are done typically to affect the contact pressures in the joint. So we thought it was an area of research, and I think there's some questions that come from this that we're trying to pursue further.
Do you ever envision a future where osteotomy to affect the slope could be done in asymptomatic individuals to minimize the risk of an ACL injury? Or is that a bridge too far?
I think it's a little too far, especially today. But I mean, never say never, never say always, but I think it's just too big of a surgery to do something like that at this point.
And I do have a question for Dr. Bram. It's heartwarming to see that the pediatric orthopedic community is moving beyond the Grulich and Pyle atlas. When I did pediatric orthopedics 30x years ago, that's what we were using. So it's great that you're deploying AI and deep learning for this. Was there any specific sex differences in the model performance? Did it perform equally well in males and females? And
Yeah.
go ahead.
Performed slightly better in males. We're not entirely, we didn't have a great reason as to why, truthfully. There were more males, like as we mentioned, 60% in the available patients. So it may just have been, these models are basically the more you put in, the better they become. And so it might have just been a volume situation where there were more males in the population included. But yeah, we are pretty excited to potentially move past Grulich and Pyle. It's developed in the 1930s and 40s in white Caucasian patients in Cleveland, so it's not the most accurate.
And another question, it was interesting finding that you want to focus on the knee for if you're doing an epiphysiodesis. How about if you're doing an epiphysiodesis on other joints, ankle, hip, whatever? Do you want joint-specific deep learning models for each of those applications?
Yeah, that's kind of our next phase, is moving into other joints. We've sort of identified all of the patients at our institution to basically have full-length lower extremity radiographs that you can then sort of segment out the specific joints for with a paired bone age. Our eventual goal, I mean, bone age is really a proxy for growth remaining. So our eventual goal is really to segment each individual joint and then be able to take a cohort of patients who have multiple full-length standing radiographs, and then therefore allow you to predict how much someone will grow in a set period of time so that you can estimate growth remaining. Because again, bone age is really just a proxy for what that is.
Well, I want to thank all the session 3 presenters. Great studies, very high quality, and I can see why you were selected to present in our national competitive conference here. So judges and presenters, please complete your scoring now. We're going to take one final break before our keynote presentation and our awards presentation. We'll see you back again in 5 minutes at 7:58 Central Time. Hey, it is 7:58. Welcome back all for our final session. So it turns out that after maligning the Pittsburgh Pirates, it turns out that the Cy Young Award winner this year was Paul Skeens, their ace. So I have egg on my face, and it serves me right. So Lee Grossman and other Pirate fans, you have my apologies. Moving forward. It's now my privilege to introduce our keynote presentation and our speaker, Dr. Brian Feeley. Dr. Feeley's schedule did not allow him to be with us in person this evening, but he graciously recorded a presentation for this evening. Dr. Feeley is an orthopedic surgeon who specializes in arthroscopic procedures to address shoulder and knee injuries in both athletes and non-athletes. He is chief of UCSF's Sports Medicine and Shoulder Surgery Division and director of the Muscle Injury and Translational Orthopedic Laboratory. Dr. Feeley has been the Conway Family Endowed Professor in Sports Medicine Research since 2022, with studies focusing on how muscle injury and recovery affect orthopedic outcomes. His research team evaluates muscle progenitor cells, looking at how they respond to different types of injury and degeneration, especially rotator cuff tears. The team evaluates and designs physical and pharmacological strategies to promote muscle regeneration. This research has received funding from the NIH, Department of Veterans Affairs, and the California Institute for Regenerative Medicine, as well as other philanthropic organizations. After earning a bachelor's degree in biology and medical degree at Stanford, Dr. Feeley completed a residency in orthopedic surgery at the Ronald Reagan UCLA Medical Center, and then a sports medicine fellowship in shoulder surgery at HSS, where he served as an assistant team physician to the New York Giants football team. Since joining UCSF in 2008, he has served as UCSF's orthopedic surgery residency, as placements and fellowship programs in a variety of leadership roles. He's published more than 300 peer-reviewed articles, review studies, and book chapters, as well as a textbook on rotator cuff injury. He serves on the NFL's Musculoskeletal Committee and on several national orthopedic research leadership committees, including in an editorial capacity. In his early career, he received Young Investigator Awards from AOSSM and the OREF, as well as the Western Orthopedic Association. He has received a teaching award from UCSF School of Medicine, as well as research awards from AOSSM and the American Shoulder and Elbow Surgeons. And in 2025, he won the prestigious Capadult Award from the AAOS, an honor that recognizes researchers who have achieved a large body of cohesive scientific work, generally reflecting years of investigation. The fact that he got his start with an OREF grant, among others, is a common theme which you'll see in many of the successful investigators in our specialty. Finally, Dr. Feeley serves as team physician for the San Francisco Giants and is part of the UCSF Health and Teams Partnership, which includes providing top-tier medical care to players, staff, and visitors to Oracle Park. He's also team physician for St. Ignatius College Prep and co-hosts the podcast 6 to 8 Weeks Perspective on Sports Medicine. So we're quite pleased to have a clinician scientist of his caliber with us tonight, presenting a talk with the title, a great title, How Not to Hate Your Job. So without further ado, let's hear from Dr. Brian Feeley.
Hi, welcome to the OREF National Resident Symposium. I'm recording this because, well, I'm enjoying work-life balance from Europe. So sorry, but not sorry. I'm pretty sure I have the best job in the world. In my 16 years at UCSF, I've had roles in education, leadership, team coverage, social media, and a lot of time in research. I wear a lot of different hats within our department, and my wife and I, well, we have a lot of kids too. Now, the structure of UCSF is unique in that we end up with some of the most complex orthopedic cases in Northern California. And I'm fortunate that I get to work with an amazing group of surgeons and researchers on a daily basis throughout a variety of different endeavors, including clinical and non-clinical work. So the premise of this talk is that the way we describe work-life balance is basically a fallacy. Work is bad. In life, everything outside work is good. And if you remember this movie and you remember what happens at the end, you know that that's probably not actually true. So this is how my week works in a nutshell. For a given week, I probably have about a day and a half to 2 days a week of clinic, a day and a half to 2 days a week in the OR, a fair amount of time with family, some time for exercise, a fair amount of time for research. Now, the problem is not everything can always go well. For every time that research tends to go well and we get good slides, we get messages like this where there's a disaster. This one costs probably about $10,000. Sometimes teaching goes great. This was when we role-played shoulder instability, where we made one of our attendings be mom, one of the other attendings be athlete, and then one of our fellows be dad, Marcus took it very seriously. To get time to exercise, which sometimes goes well. Sometimes my wife makes me run across San Francisco, which was a little bit of a disaster. And sometimes surgery can go well. And as we all know, surgeries sometimes don't go so well. So that was the revision of that, which sounds like it went well until you see what actually happened, which was a little bit of blood loss. And this is me putting in what I thought was the blood loss at the end of the case. So turns out you can only lose so much blood. So to get us on the same page, true or false, the average person works harder or longer now than they did 50 years ago. Since this is a recorded talk, I'm just going to give you all a couple seconds, and you're all going to say, well, if I'm asking, the answer is probably false. And you're right. We don't work as hard as we used to, especially in some countries. We work a lot less hard, particularly Germany, awkward, but we are trending down by about 30 to 40% over the last few years. Another true or false, we are less happy in our jobs in medicine than we used to be. Well, it depends. I'd like to say that Edgar here is, it's true because sports-bound residents are happier, but it is true we are less happy even though we are working less. Now, according to multiple studies, there are factors that people cite to make them feel satisfied at work. And I'm going to try to frame some advice on how to enjoy work as much as possible around these. And these all go back to the idea of mattering, the importance of feeling valued or adding value to other people's lives. And I find this to be particularly important because my wife, who is a writer, wrote this, and I keep going back to this article that was in the New York Times about 2.5 years ago. That making people feel like they matter within their work is really important in making you feel like you are appreciated, and then you will enjoy your job. So my overarching rule is that you actually have to work on making work as good as possible. It's not effortless. And this general idea of deliberate practice was championed originally by Anders Ericsson and has been simplified, thanks to Malcolm Gladwell, to the 10,000 hour rule. And if you think about what you want to be good at and how much effort you put into it, for me, I want to be really good at surgery. And I think I'm an expert at ACL surgery and instability. I don't think there's anybody that does a better instability surgery than me. But then I think about things I don't do as well. I think I'm pretty good at doing EMR, but I could always work on that better. And I'm really bad at diagnosing C-spine pain in clinic. It tends to be a conundrum every time I see it. And when I think about these things, a lot of our tasks fall into this middle category. We don't suck, but we don't really embrace being really good at it. And then that is the thing that really ends up feeling like work. And I won't review this too much, but these are the rules of deliberate or intentional practice, where you start with goals, you slow down, you kind of chunk it out, you practice different parts of it at the edge of your ability. So if you think about how you're training to be a surgeon, we tell you do this part, do this part, do this part, and then we add to it. And then we tell you what you did well and what you didn't. Sometimes we're a little bit heavy, but you can see even for this, you get the little shit sandwich of feedback. And then you do it again. We give you a harder case. You start thinking about when you're getting good at it, and you do this over and over and over again. And as we go through my suggestions for this, I try to go back to this repeatedly, at least in my mind. Am I doing this for work? Am I also doing this for surgery? Because I think in making our life feel like it's manageable, this is how we do it. So my first rule is to be intentional with your choices. Why do we want to say yes to this? And when I say no, why am I saying no to something? And this is something that Tab Zaire, who's at Hopkins, is really good at figuring out. As junior faculty, you always say yes until you no longer have the space, and then you have to start saying no. So the reasons why you say yes: it's good for intellectual stimulation. It's good to build your peer and mentor groups. Gives us a sense of the ability to innovate and create. If you say yes to too many things, you will be taking fairness away from others, and it can lead you to feel a little bit out of balance. So when I say yes to something, I usually think about it, but raise your hand, or, silently think about it if you've said, yes, I'll do it, and then regretted signing it for something in the last year. And almost everybody, particularly in research, has something that they're just like, why did I say yes for this? So you do have to be careful. So when I say yes, it is something that I want to do. It brings me some sort of professional or personal gain, or it helps others around me. So this is a little example of a recent one. So I met with these people, and they said, we want to talk about one of the lab tools to look at patterns after injury. I was like, okay. So I like new research. Any new tools get me really excited. It brought me a little bit closer to these guys, Alan Bussbaum and David Julius. David Julius has a Nobel Prize. I want a Nobel Prize, or since I'm probably not going to get one, I want to at least touch it. If I say yes to this meeting, it helps a bunch of different people, including me. I get the new research that I want. So overall, I think it's a value added. But once I've said yes, I set a time or term limit. And then once I start doing it, what are the benefits and how can I maximize those? I try not to procrastinate. All of us do some, but I really, once I say yes, I try to just get started on it. And then I go back and reflect on what worked and what didn't. And do I want to do this again? And I think that's really important, especially for things like research and some education tasks that can kind of take up the entire part of your extra time. And one of the things to think about is it's so hard to say no to things. We're trained to say yes, but when we say no, it is rare that people remember. And this is key for medical students and residents, particularly residents. When you say no thanks, there actually really aren't any repercussions. If you say, no, I don't have time to work on that research topic, we just move on. So when we say no to something, I think of it as this value over replacement thing. When I say no, okay, maybe I don't necessarily get as much intellectual stimulation, but it opens me up to do something else. It increases equity and fairness. They're going to pick somebody else, and it definitely increases my feeling of balance. So when I say no to something, I usually try not to say it right away. And this is something that my wife has taught me, is especially in a leadership position, don't just say no, say, let me think about it. Can I say yes for somebody else? I was recently offered to give a speaking engagement that I was like, oh, I'd love to do it, but I actually do a lot of these. One of my junior partners doesn't do as many, so let me say yes for him, and he was super excited. And then what is the value loss of saying no to something? It's usually less than we think. And what is the value gain to another facet of life? So when I say no to something, what does that open me up to doing, or what does that allow me to maintain? Now, the second thing is keep your interests broad. So for clinicians, that means see more patients early on. As a surgeon, know your limits, but try to figure out what you're good at. Try different cases early on, and then figure out what sort of bonus work you actually like. And this may change over time. You may start not being a researcher and you may grow into doing that. You may decide, like I did, that I didn't really want to do education, but then when I started doing it, I was like, actually, I kind of like it. And then some people love the administration of healthcare. That's not for me, but to each their own. Now, why actually keep your interest broad? I think it checks all the boxes. You're intellectually stimulated, you meet more people, it's usually fair. You have the ability to innovate, you increase your feeling of advancement, and depending on what you see as keeping your interest broad, that can be outside of work too. So it does lead to a feeling of balance. But this is the paradox of being a junior faculty, and all of you will see this relatively soon. This is Drew Lansdowne, who says every time I want to say yes to something, people tell me I need to focus down. Why is that when those who are the exact people who are doing everything? And this is true. We tell you your whole life, go out and be good at everything. Then you become a faculty member and we say, you've got to focus. You can either be an educator or a researcher. You can be a good surgeon, but you can also have a lot of administrative roles. And as you grow and mature as a person, your interests will change, but I don't want you to think that you actually have to narrow down. I think you just have to be a little bit selective. So the way I like to think about this is once you know your interests, eliminate what you don't like. So for me, as a clinician, I got rid of hip arthroscopy. Turns out I kind of sucked at it. I didn't like seeing those patients. As a surgeon, I continue to try to focus. I got rid of hip arthroscopy, got rid of lateral meniscus transplants and multi-leg knees. Drew, Michael Davies, they're just better at it than I am. Alan Zhang and Steph Wong are much better than hip scopes than I am. And then for bonus work, I keep adding research. I love education, but I try to keep it contained into who I educate well, which is fellows, residents, and medical students. And I'll give some random other talks, especially to high school students, because I think I'm funny. I don't love administrative work, so I try to really not do too much of it. The next piece of advice is choose your mentorship and support team wisely, because I think this is really, really important. And then if you're extra nice, like with Alan Zhang, you bring them with you to Hawaii for weddings and other trips. Now, according to multiple studies, these are the factors that people cite to make them feel most satisfied. But the number one thing is a good mentorship team. So I think this is vitally important. And the way I like to think about this is that it isn't just one person. So while not everybody can be an expert on everything, I try to lean on teams of people to get advice and mentorship. Probably most importantly too in this group is the Am I Being an Asshole group, which is my wife, Rob Gallo, one of my former fellows or co-fellows, and Drew Lansdowne. Like, this happened at work. Am I thinking of this the right way? Or this happened at home or socially. Am I thinking about this the right way? And that's vitally, vitally important. So my fifth piece of advice is be deliberate about time management. And I am definitely a tadpole to Kevin Bozick's Bullfrog. He has amazing talks about this, but you have to be really intentional about how you manage your time, especially as you get busier and busier. And as residents, you think you're really busy, but the reality is as you get further along, you get busier, you get older, and you have more and more responsibilities. Now, good time management skills really hit the intellectual stimulation because you can do more. You have the ability to innovate and create for sure. And it can really, really help with that feeling of balance. Now, it's a whole different talk on time management, and it's really, really outside my skill set. But here are some general tips, and pretty much every top 10 to top 20 list has these first few. So get organized for every day. That often starts the day before. So for me, clinic the day before, I look through things. Obviously, the day before an OR, you look through things, make sure there's no surprises coming. For me, that also means my most important time is in the morning. I try to leave, get to work early, get some stuff done, because that allows me to focus and get a lot of the little things that came in the night before, a day before, out of the inbox, so to say. Second thing that comes up over and over and over is the one-touch rule. Once you're in your email, get it done. Don't look through and just scroll. If you're going to answer emails, answer emails. Same thing for charts. Once you're in a patient chart, don't doom scroll through a patient chart just to take a look. Once you're in that chart, get it done and then move on. Don't go back and forth. The reality is our brains don't switch tasks well, no matter what you think. Most people don't do it well. Less than 1% of the, less than 2% of the population is actually proficient at multitasking. And ironically, it's these people that are least likely to actually multitask. The problem is we all think that we're one of that 1% to 2%. We're not. So realistically, don't multitask. One way to think about it is mindfulness and multitasking are competitive inhibitors of each other. And when you're trying to multitask, you're basically constantly failing at both things. So do one thing, get it done, do the next thing. In terms of looking at time, it's really complicated because I don't think that there is a perfect answer, and I haven't found a great book to really say this is what you should read. I try to not book things into the future if I can do them right away. And if you don't want to do something, just say no. For a variety of different reasons. I think the thing that I do worst is I will sit there and say, I don't want to have this meeting with somebody, so I put it off for 2 months' time, and then all of a sudden that week comes, and that week has been piled on. So if you don't want to do something, don't book it into the future, just get it done. And then really, really important, know your limits. Organize the day so that you are done by the end of the day. That doesn't mean done and go home and write charts for the next week. That means you are done when you leave clinic, you have finished your last note, you don't have 2 hours of work when you go home. So figure out how many patients are realistic for you. I found that my sweet spot in a day is somewhere between 32 and 36 patients for a full clinic day. It is not 70, but it's also not 20. If I see a few less, it really doesn't matter. Big picture. So I make sure that my schedule is somewhat curated. I see everything coming in, so it can be a kind of potpourri of disaster. But what I actually do at the given day and number of patients is enough so when I'm done, I'm done. Same thing for the OR. Can you really do that case in 60 minutes? If you can't, book it for 90. You will be happy, your OR staff will be happy, and then your family will be happy because you're being honest. And I think this is one of the most challenging things, is that the tool we use most at work is really our EMR system. And we have learned to hate an EMR system. And all of us that are old kind of begrudgingly hate it, but also can quietly go back and think, yes, but this is the most important thing. And it's so much better than paper charts. It's painful, but attend the sessions to improve how you use it. Deliberately practice your use to streamline daily practices. I try to spend 20 to 30 minutes a week of either reading about the EMR, it's super boring, or updating phrasing, something that'll make my patient encounters smoother. And in a perfect world, we would cover this, and we would have experts within divisions and departments, but we don't. And finally, constant finally, a constant reappraisal of your life and responsibilities. What's working? Do I have time for more of it? Do I like it? Am I still going to like it in a year, or is there somebody else better? And then in terms of, why is it not working? Why not? Is this a modifiable problem? And you get into this a fair amount, where it may not be a modifiable problem. If it's not a modifiable problem, ignore it. You might not be able to do anything about it. If it is not modifiable, how do I tolerate it? And if you can tolerate it, is that okay? And then I think it's always important to sometimes just be a goldfish and forget. Remember, sometimes good cases aren't so good. So this is relatively recent cases for me. I had this guy, dislocation at 5 weeks, revision, then he got infected, then he got dislocated, dislocated again. Finally, we fixed him with cerclages, and he's now a success story, but still sucks. This one in the middle is still a disaster. She failed at TSA. We revised her subscap. She failed that. She got a reverse. She failed to reverse. She got infected. She failed to reverse again. She got a hemi. The hemi literally fell out of her humeral shaft. And then we went back in, revised everything, couldn't fix the glenoid. So she still has basically a cement spacer in there. And this is a ladder J that, everything worked out okay, but it was just a disaster. And then you can get hurt from other ways too. These are patients that wrote in their experiences. And then my personal all-time favorite is this one. And I'll give you a second to read this, but I can also read it. I would like by this chance to give comment on Dr. Feeley, Brian. Also, he works in the same department. This is a patient who was not seeing me. She was seeing one of my partners. I know who it is too. I saw him before. I found he is fat. I'm not fat. To be an orthopedist, you not only need intelligence, but also physical strength and potency. Don't even want to touch the potency. I've got 5 kids. He gives the patient impression he doesn't have physical strength. He is with tremendous belly fat and not fit. A surgeon should be different from internal medicine doctor. Awesome. I would never recommend my friends to visit Dr. Feeley. Great. Thank you very much for that. So does this lead to balance? And I think overall, doing these things and trying to think of your body or your life as a variety of different posts, not just a teeter-totter, makes things a little bit better. So if you think about every little thing as supporting your balance, I think it's easier to have more things to balance on. And with that, I will wrap up. I wish I was there in person. I'm sorry I couldn't be there. I think the OREF is wonderful. I love all the support they do for residents. I got my first grant ever from the OREF. I got a career development from them. I think it's a wonderful, tremendous opportunity for you all. And I think they've done a great thing and really just driving research forward. And I appreciate this opportunity. Thank you.
Well, thank you. That was an outstanding presentation by Dr. Feeley. I wish I had heard it about 40 years ago, but there's some really good lessons for all of you on how to manage your time and how to, as he says, not hate your job. I agree with him. I think I got the best job in the world, and some intentionality around some of the choices you make, I think can assure that for all of you. So now, without further ado, I'd like to announce the winners of our competition. Actually, all 14 of the presenters are winners. There was really outstanding research presented, and it was quite difficult to choose the best of the best here. So first, I'm going to announce the 5 finalists who received top investigator awards. Then I will announce the Presenter's Choice Awards. And finally, I will announce the grand champion for the OREF awards. So for the top presenter awards, as adjudicated by our judges, we have 5 individuals, and I'll announce them in alphabetical order. The first is Dr. Joshua Bram from HSS, who discussed the skeletal assessment from knee radiographs using deep learning. Congratulations, Dr. Bram. Dr. Bhargavi Maheshwer, sorry about the pronunciation, from the University Hospitals Cleveland Medical Center, who presented on predictors of ACL re-injury and return to sports in adolescent athletes. The third is Dr. Katherine Montoya from the University of Arkansas, who presented on 10 years of a novel telemedicine system for management of statewide hand trauma in Arkansas. Erik Nakken from the University of Michigan, who discussed optimizing contact pressures of the posterior heel during lower extremity immobilization. And the last in this award category was Dr. Sreetha Sidharthan from HSS on reverse anatomical front and back reconstruction for volar intercalation segment instability. So congratulations to these 5 individuals who will receive $500 cash awards. In the second category I present is the presenter's choice. So this is the individual who was determined by the other presenters to have given the best presentation today. And for that, we congratulate Dr. Alexander White from the Hospital for Special Surgery on the effect of posterior tibial slope on tibial-femoral joint biomechanics and in vitro analysis. So finally, I will announce our grand champion. This individual received travel expenses and registration to the AOS annual meeting in New Orleans this coming March, and will be recognized at the OREF Board of Trustees reception, which will take place during the AOS annual meeting. Congratulations to Dr. Julia Retzky from the Hospital for Special Surgery, who gave a presentation entitled Early ACL Reconstruction Mitigates the Effects of Post-Traumatic Arthritis in a Marine ACL Ligament Rupture Model. Congratulations, Dr. Retzky. Outstanding study, well-deserving of this Grand Champion Award. So again, I want to congratulate all our winners and to everyone presenting tonight and all those presented at the regional symposia. The quality of research presented this evening was outstanding and gives me warm and fuzzies about the future of our specialty. I am certain that this evening we have heard from more than a few of our future clinician scientist leaders. And as we've heard from Dr. Feeley and others, it's the OREF where we got our start. So it's important that we all understand the importance of the OREF in our specialty and that we give generously throughout our careers to the OREF. Now I'd like to welcome back Lee Grossman to provide a few closing remarks.
Thank you, Dr. Jacobs. First of all, congratulations to the award winners and all who presented today. It was an outstanding symposium. Thank you all for participating. Thanks also go out to the OREF staff, and particularly Dr. Deborah Cummins and her team, Carmen and Dolores, for putting on not only this symposium, but the symposia that happened throughout 2025. Thank you also to our generous sponsors, J&J MedTech, Smith & Nephew, Zimmer Biomet, and the Hark family. We are always very grateful to our judges who give us their time and their expertise at each of our symposium, and particularly the ones tonight, Drs. Pollack, Silva, and Snyder. When we get a chance to talk to Dr. Feeley the next time, we'll certainly thank him for this remarkable keynote that he gave this evening as well. And Dr. Jacobs, thank you for your leadership, not only with OREF, but your special moderating skills that you presented tonight. Lastly, thank you to all the residents who presented today and the almost 100 residents that participated in the symposia over 2025. And finally, with the changes and the declining funding in MSK research funding, OREF's mission is now more important than ever. Please support OREF with a generous gift so we can continue to grow the pipeline of clinical researchers, drive innovation, and improve patient outcomes. To all, I wish you a very happy and wonderful holiday season. Thank you.
Thank you, Lee.
That concludes our program. Thank you all.
Good night, everyone.